Welcome to Critical Care Medicine in 10 minutes or less. Caring for patients with critical illness is complex and occupies an extensive list of medical and surgical pathologies, many of which we will be unable to cover in this video alone. This video is meant to be a primer and to help distill down topics our group can be expected to manage acutely, often with little or no consultative help. We hope to add additional content and topics to this lecture series as we continue in the future, and we thank you for watching. Okay, we're going to take 10 minutes to go through post-resuscitative neuroprotection and the institution of targeted temperature management. We'll go through basic theory, clinical approach, and some upfront troubleshooting that we'd like you guys to think about. Okay, so real quick history. We've been talking about the benefits of cold therapy for a long time, dating back to Hippocrates in 400 BC, where he spoke about the benefits of cold therapy on the central nervous system. Case reports of people coming back from the dead while being cold with no neurologic injury. Some of the earliest being Anne Green, who was put to death for infanticide and witchcraft in 1650 on a cold autumn day. Was brought back to life spontaneously during autopsy and had no neurologic deficit. One of the famous reports was the orthopedic surgical resident who suffered a back-country skiing accident and was pulseless for over 80 minutes and had a core body temperature less than 32 degrees, who recovered with no neurologic injury. So we've been talking about this for a long time. The mechanism of injury in cardiac arrest is pretty simple. Cerebral anoxia leading to ATP depletion, loss of cellular structure and integrity, excitotoxicity, calcium influx, and apoptosis. But the injury isn't done there. What we worry about most is the post-ROSC injury of reperfusion and inflammation, where you don't have blunting of that cascade, and that can last for hours a day after return of spontaneous circulation, compounding neurologic cell death. So some of the concepts that we believe are impactful from neuroprotection directly inhibit that post-resuscitative inflammatory cascade. By maintaining blood vessel permeability, directly blocking apoptosis, maintaining cellular structure through metametalloproteinases, decreasing oxygen demand, and overall inflammation by interleukins. There have been various clinical trials. Everyone's familiar with the Bernard and Hackett trial from 2002 that looked at VT-VF arrest in 33 degrees, which was standard of care up until about 2013, following the dosing trial of TTM for mild hypothermia versus milder hypothermia, 33 versus 36, which led to a lot of us to reform our practice, because certainly 36 degrees, where there's still benefit associated, is far less labor intensive, and there are fewer side effects like coagulopathy, bradycardia, and electrolyte abnormalities associated with 36 degrees. Something that everyone also needs to remember is that hyperthermia in the cardiac arrest patient is associated with a worse outcome, and that goes with anybody with neurologic injury, not just people post resuscitation, but also traumatic brain injury or stroke patients. That hyperthermia or hyperpyrexia is associated with a worse outcome. So in combination, we work to support patients with cold therapy as well as prevent fever. And this should blunt that post-resuscitative inflammatory cascade that we're trying to work on. Okay, if you're asking yourselves, well, do we just do VT-VF arrest or do we do it for all rhythms? The answer is all rhythms. Although you can certainly see that there's a difference in benefit by CPC neurologic scaling for patients who are shockable versus non-shockable rhythms. We do believe that there is some benefit in specific cohorts of patients who are non-shockable, and therefore, since it is not particularly labor intensive, we're going to cool everyone. Okay, so what do you need to know to do post-resuscitative neuroprotection here at Cooper? Know the inclusion criteria, which is any rhythm. We just discussed that, and the patient must be comatose. So following return of spontaneous circulation, if the patient is unable to exhibit higher order executive function, then we will cool them. Meaning if you can move all four extremities thrashing incoherently, that does not count as being awake. Okay, we expect you to be able to direct executive function, otherwise you will be cooled to 36 degrees. The only absolute contraindication honestly, because this is so well tolerated, is an advanced directive against aggressive support. Cooling will happen one of two ways: externally cooling patients with pads, preferably with the Arctic Sun device, or internal cooling through an internal cooling catheter, which is the Zoll device. When all the Arctic Suns are in use, we will use the Zoll internal catheter. The 4 phases to remember are induction, where you'll make the decision to start cooling the patient. You'd like to make the decision whether to institute hypothermia, preferably within 2 hours, but by protocol up to 6 hours. We would like to get that patient to goal temp of 36 degrees by 6 hours. Once we have them at goal temp, we will maintain that temperature for 24 hours and then begin the rewarming phase, where we're going to rewarm slowly at about 1/4 degree centigrade per hour. You may ask, why does that matter? Most of the data looking in post-resuscitative care shows that if you rewarm too quickly, you may have a washout of overall benefit. Okay, so the goal is going to be between 0.25 degrees centigrade and 0.5 degrees centigrade per hour. And then post-rewarming fever prevention, like we just talked about, that hyperpyrexia is associated with worse outcomes, is going to be very important. We're going to use external cooling, so we're going to maintain those pads for an additional 24 hours to keep them at 37 degrees centigrade. And then we'll remove those pads and treat them pharmacologically with things like acetaminophen to maintain a temperature of 37 degrees. Okay, the targeted temperature management order set is available in Epic. It has all of the things pre-selected for you, except for which device you're going to use. You're going to have to make that decision. Labs and nursing interventions will be pre-selected. We'll also have a shivering protocol pre-selected for you to help troubleshoot through early shivering to get to goal temperature. Some of the things that I think that we need to think about up front when we decide to cool a patient, number one is to avoid hyperoxia. So after this patient has been resuscitated and we have them attached to the ventilator, we want to avoid hyperoxia early in their management, because some of the data that came right out of Cooper from Dr. Roberts and Dr. Kilgannon have showed that hyperoxia is associated with a worse outcome. So our targets are going to be a saturation of 94% and a PaO2 between 100 and 120, something around there, okay? So we expect that you guys titrate your FiO2 early and quickly. Number two, one of the things you're going to come up against up front is going to be seizures and myoclonus, right? Really depending on their degree of downtime. Seizures and status epilepticus are very common. We're going to use benzodiazepines IV push up front to help abort seizure activity, because the mechanism of injury that happens in an anoxic event from cardiac arrest is the exact same mechanism of injury that comes from prolonged seizure and status. So we're going to abort that seizure with 0.1 mg per kg up to 6 mg up front, and then we're going to maintain them preferentially with Keppra, your own propofol, and if the patient is on a continuous EEG and in status, we'll probably start a benzodiazepine infusion and titrate to burst suppression. At that point, we're going to get neurology involved early, and they're going to help select some alternative AEDs like glucosamide valproic acid, or for super-refractory status, potentially even ketamine. For myoclonic status and jerking, these are things that you're going to see up front. Often myoclonic status seen early in arrest is associated with a worse outcome. We're going to try to abort myoclonus with IV push benzodiazepines, and then maintain them with Keppra. And oftentimes, the midazolam infusion works best for myoclonic status. At that point in time, if there's concern for myoclonic status, they'll be on a continuous EEG with neurology and consultation to help assist you with burst suppression management. Lastly, neuroprognostication. Following the advent of post-resuscitative care, we commonly waited 72 hours, and through various clinical exams, we're able to neuroprognosticate. It's a little bit more of a gray area today, since we have such aggressive post-resuscitative care. We're going to usually wait up to 72 hours before discussing with family, but that can depend clinically on how long the patient was down and how bad their clinical exam is. Neuroimaging will occur up front, CT and MRI, looking for gray-white matter differentiation on CT and severe anoxic injury on MRI. They'll get EEGs, one to rule out non-convulsive status and the other to look for slowing. If there's concern or it's unclear that based on exam and imaging as well as EEG, that the patient will not do well, we can do bilateral SSEPs, which are somatosensory evoked potentials, to look for communication between the brainstem and the higher cortex. Bilateral absence of N20 SSEPs is associated with a very bad prognosis. So it helps us communicate with families a little bit more. We don't perform neuronal-specific enolase, as it has a very high false positive rate. We will involve neurology very early, including continuous EEG, to help communicate with family, and we'll involve palliative medicine as well. I hope this was helpful in guiding at least a basic approach to the use of targeted temperature management post-arrest. Thank you.
We are going to discuss the different classification and etiologies of shock, and then try to titrate our medical management based on each etiology. So in order to start, we need to define shock, and that's inadequate tissue perfusion that results in cellular injury. Ultimately, there's release of inflammatory mediators that further compromise tissue perfusion and will result in end organ failure. It's important to think about shock in two states: the macroperfusion, so hypotension, increased lactate, and also the microperfusion defects, in which there's anaerobic metabolism at the cellular level. And our treatment is to restore both of these to a normal state. Shock was first identified by a French surgeon, Henri Francois Ledron, in the setting of a gunshot wound, and it took almost 100 years until the next clinician, Edwin Morris, described it in a non-traumatic state. We continue to do research yearly based on the different treatment options in the setting of shock, but also looking at the physiology at a microvascular level. When we really read on shock, we see a lot of these charts which look at respiratory rate and heart rate, cardiac output, systemic vascular resistance. And what I think is important in this slide is to recognize that many of these shock states will overlap. So as a couple examples, in septic shock, about 50 to 60% of patients will have an associated cardiomyopathy. Or patients who have prolonged hemorrhagic shock or cardiogenic shock will have upregulation of nitric oxide, resulting in vasodilatation and a component of distributive shock. So when you approach these complex patients, it's essential not to just have early closure on a single diagnosis of this is sepsis. A patient can have a urinary tract infection, but they could also be in shock in the setting of their pericardial effusion with tamponade. So going through each shock state, our first will be cardiogenic shock, which is driven primarily by decreased stroke volume and cardiac output. There's some myocardial injury, whether it's structural changes such as new regurgitation or myocardial ischemia in the setting of acute occlusion, that will result in decreased stroke volume and cardiac output, leading to further hypotension and decreased coronary perfusion pressure, which then will aggravate this ischemia and further spiral down into worsening perfusion. These patients will present hypotensive, and particularly with cool extremities, because their systemic vascular resistance is so increased that they're having clamping down of their external organs, and really trying to shunt blood flow to the organs like the brain and the heart and the lungs. As we'll discuss, our treatment plans are going to be with ionotropic therapies such as milrinone or dobutamine, but we need to maintain a mean arterial pressure to optimize this coronary perfusion and perfusion to end organs. So very often these patients will need an associated vasopressor such as norepinephrine. As we treat shock with our medications, it's also important to look for the cause of the shock and see if we can correct this, whether it's a surgical intervention or revascularization in the cath lab. The most common form of shock you'll see in the ICU here will be distributive shock, which can be anaphylactic shock or septic shock. Septic shock is driven by a cytokine storm causing inflammatory markers to result in vasodilatation. Think about these patients like a plumbing system. Their pipes are all big and dilated, so the normal intravascular volume that you have is inadequate to fill those pipes. So what we need to do is optimize them to an appropriate volume status, but then also add on medications which are going to clamp down on those pipes. So norepinephrine is going to be your agent of choice initially, given its alpha component with a little bit of beta activity, which we'll show later. And there's also a beneficial side effect profile. As you go up on norepinephrine to restore that mean arterial pressure, you may need to add a second or third agent, and vasopressin and epinephrine tend to be our second agents of choice. It's important to talk about stress dose steroids in the setting of septic shock. The literature is varied, showing the plus or minus benefit on mortality, and the typical agents used are hydrocortisone or hydrocortisone plus fludrocortisone, as this was the regimen used in the Approaches trial, most recently showing some mortality benefit. So as we approach our second or third vasopressor agent, we can consider adding on stress dose steroids, although cortisol levels will not be helpful in making this determination whether the patient will benefit from this therapy. Patients with hemorrhagic shock will present with hypotension, pallor, cool extremities as their systemic vascular resistance is increased as their body is clamping down. It's important to correct any metabolic derangements such as acidosis, which can aggravate coagulopathy, or get somebody back to normothermia, as cool temperatures can worsen coagulopathy as well. If there's any reversal agent that's needed for someone with an elevated INR, or if they've been on an oral anticoagulant, this is going to be essential here. And in our transfusion plans, we're going to use a 1:1:1 ratio for the most part, that is plasma to platelets to red blood cells, when we're going over about 6 units of packed red blood cells. It's essential to remember to replete any calcium as we get up to higher doses of red blood cells as well. An important form of shock not to miss is obstructive shock. And very often we'll find patients are diagnosed with something like UTI because they have a positive UA and are in a shock state, and then we find out later that they actually have a pericardial effusion secondary to cancer or renal failure resulting in tamponade. Patients will present with hypotension, jugular venous distension, and they will have some other risk factor for obstructive etiology. The ventricular outflow tract is either obstructed or there's obstruction into the filling of the great vessels, leading to decreased preload and shock. The typical causes of this will be massive pulmonary embolism, which will result in increased right ventricular afterload, causing the RV to dilate and then impinge on the left ventricle. Further causes are pericardial effusion, like we spoke about prior, or even tension pneumothorax after line placement. While vasopressors may be helpful here as a transient measure, these obstructive lesions need to be decompressed, whether it's with chest tube or pericardial centesis, or offloading of the right ventricle with some pulmonary vasodilators or diuresis. Neurogenic shock is relatively rare to see. It's usually associated with decreased sympathetic activity resulting in hypotension with an associated bradycardia. Most patients will have some neurologic injuries such as spinal cord injury above the level of T5. Treatment here is customarily with phenylephrine as an initial vasopressor, although other agents such as norepinephrine are certainly reasonable. Here we need to say that lactate is not the only marker of shock. Lactate can be elevated due to end organ perfusion deficits in the setting of shock, but also can be driven by hepatic congestion, thiamine deficiency, certain medications such as albuterol that drive increased beta activity. So when we see someone with an elevated lactate, we have to look for the source of why and keep an open and broad differential diagnosis. In some of these shock states, such as hepatic congestion due to right heart failure, further fluids will actually worsen hemodynamics and further increase lactate levels. So in a short time, we're going to discuss vasopressors. So often you see charts about the alpha and beta activity of each vasopressor, and they're not very helpful in the clinical setting. But here we see a comparison of all the alpha and beta activity in the form of vasoconstriction and positive ionotropy. Norepinephrine will be your primary vasopressor of choice in most shock states. And the reason for this is that it has a beneficial side effect profile. Norepinephrine will have some alpha activity causing vasoconstriction with a modest positive ionotropic activity. It won't cause significant tachycardia for the most part, and in comparison to dopamine has decreased arrhythmogenic components to it, and when compared to epinephrine has no change in mortality or outcomes in the setting of septic shock. Because epinephrine will increase your insulin requirements, may drive your lactate higher, and therefore you lose it as a marker of resuscitation. It also increases your risk of digital ischemia. Norepinephrine tends to be the agent of choice initially. Next, as we look at a second vasopressor in the setting of distributive shock, in particular, vasopressin and epinephrine are both reasonable. Vasopressin acts on the V1 receptor, causing strict vasoconstriction without any beta activity. It's used at a fixed dose of 0.03 units per minute, and actually spares the pulmonary vasculature. So someone with acute pulmonary hypertension, for the most part, will have improved vasoconstriction of the systemic circulation, but will spare the pulmonary vasculature. Epinephrine is helpful in the setting of increasing heart rate if needed, if a person has some cardiomyopathy and needs a little bit of a higher heart rate, or even some help with contractility. And then our last major vasopressor will be phenylephrine, which is customarily used in the setting of tachyarrhythmias when other vasopressors have been used. So a great example is atrial fibrillation with RVR. You'll transition over to phenylephrine, and that may be helpful. There is no randomized control trial to show that this improves mortality. However, we use it in clinical practice very often. This should be used with significant hesitation, particularly in patients who have acute pulmonary hypertension, as it can increase right ventricular afterload. Dopamine is more of a niche vasopressor, which has increased arrhythmogenic components to it, and therefore we don't use it very often. The one clinical condition in which you'll probably use it will be bradycardia with associated hypotension, and the increased chronotropic and ionotropic activity may be helpful here. Epinephrine in this condition is also a reasonable option. And our last two agents are Butamine and milrinone, both of these work to increase intracellular calcium and increase ionotropic activity, but they'll have vasodilatory component. And so in order to maintain your mean arterial pressure, very often you'll need to use another vasopressor, and most usually will use norepinephrine in this setting. Milrinone is classically renally cleared, and therefore if you have someone with AKI and you're using milrinone, then you'll have potentially a longer activity of this milrinone and persistent hypotension even if you stop the medicine. Milrinone also bypasses beta activity, which is the target of dobutamine, and so if you have someone who's chronically beta blocked, theoretically milrinone will be more helpful here as an ionotropic agent. And this will be our last slide today, looking at different scenarios that may be helpful in particular. So patients who have atrial fib with RVR, phenylephrine may be helpful given lack of beta activity. In bradycardia, you may need more beta activity using dopamine and epinephrine. Think about vasopressin in the setting of pulmonary hypertension, as the vasoconstrictive components spare the pulmonary vascular tree. And lastly, in cardiogenic shock, you may need to add a vasopressor to ionotropic therapy to maintain your mean arterial pressure and end organ perfusion.
ARDS is an acute diffuse inflammatory lung injury that leads to massive capillary leak and loss of aerated lung tissue. The clinical hallmarks of ARDS are really the acute onset of severe hypoxemia in the presence of a predisposing illness, as well as bilateral infiltrates on chest x-ray that are not thought to be cardiogenic in origin. In 2011, ARDS was redefined under the so-called Berlin definition by the critical care societies, where they included 3 mutually exclusive categories of ARDS based on the degree of hypoxemia. So mild ARDS would be a PF ratio of less than 300, which is the PaO2 over FiO2. Moderate would be less than 200, and finally severe would be a PF ratio less than 100. Now, the severity of ARDS both can help predict mortality, where severe ARDS often has a mortality of over 40%, but it's also important for thinking about the therapies that are indicated. There are some therapies that we only reserve for those in the severe ARDS category. There are many diseases that can predispose patients to developing ARDS, the most common of which is direct injury to the lung by either pneumonia or aspiration. However, indirect injury from the cytokine release, either from sepsis or trauma or massive transfusion, even acute pancreatitis, can cause ARDS. In ARDS, ultimately, the alveolar epithelial cells are injured, and this really compromises the barrier of the alveolar membrane, causes influx of protein-rich fluid that floods the alveoli and impairs gas exchange. Additionally, these type 2 pneumocytes are the cells that make surfactant, and when they are destroyed, the lack of pulmonary surfactant increases the alveolar surface tension, causing both atelectasis and shunt that drives the severe hypoxemia. Ultimately, patients can progress to severe fibrotic lung injury as early as 5 to 7 days after the onset of the disorder. When we look at a chest x-ray of a patient with ARDS, it looks like this symmetric, homogeneous process of alveolar filling, but what we find when we examine a CT scan is that lung water and atelectasis and consolidation really goes predominantly to the posterior lung zones from the presence of gravity, and it's the anterior alveoli that are more effectively aerated. And this has led to the concept of the baby lung, where while we might predict the lung size based on a patient's height, we're really only functionally aerating a much smaller proportion of the anterior lung. Part of the treatment challenge in ARDS is that mechanical ventilation, while necessary and life-saving, can really perpetuate lung injury due to overdistension. And when we use excessive tidal volumes in ARDS, we term that volute trauma. And excessive tidal volume can also lead to high transpulmonary pressure, which is called barotrauma. And then finally, just the repetitive opening and closing of the alveoli can cause atelectotrauma, as well as the biotrauma that occurs from the release of inflammatory cytokines. Over the past 20 years, the NIH has funded this network of clinical trials called ARDSnet. And most of the literature that we employ in our strategies to ventilate ARDS patients come from these landmark ARDSnet trials. And so that's what I want to spend the majority of time talking to you today about, is the approach to mechanical ventilation of the ARDS patient. And the hallmarks of that approach are really lung protection. So limiting tidal volume, limiting plateau pressure, limiting driving pressure, which we will talk more about, being permissive with hypercapnia and allowing respiratory acidosis to occur, as well as targeting oxygenation targets that are not too high and not too low. And we will talk about the specifics of that. And finally, I want to end with discussing what do we do when, despite those lung protective ventilation strategies, we still have a patient with refractory hypoxemia. So really the fundamental concept of lung protective ventilation is predicated upon using a restricted tidal volume. And to calculate that tidal volume, the first step is actually to either measure or ask the family the height of the patient in order to calculate the predicted body weight. We then set the tidal volume at 6 cc's per kilo of ideal body weight. Once we have set that tidal volume, we measure the plateau pressure with an end inspiratory pause. The reason we both limit tidal volume and plateau pressure is that the ARMA trial showed a 22% reduction in mortality by lowering the tidal volume to 6 cc's per kilo and keeping the plateau pressure under 30 centimeters of water. So if you find that the plateau pressure remains over 30 despite having a tidal volume of under 6 cc's per kilo, the next step is then to lower sequentially the tidal volume in 1 cc per kilo increments until you achieve a plateau pressure under 30 centimeters of water. Clearly, with this strategy of lung protective ventilation and limit of tidal volume, we are going to lower the minute ventilation. And as a result, the PCO2 will rise and the pH will drop. This whole strategy is acceptable, and we call that permissive hypercapnia. Now, we will be permissive in the range of, we'd like the pH to be 7.3 to 7.45. We will tolerate a pH down to as low as 7.15 according to ARDSnet. If we find that the pH remains low, below 7.15, despite increasing the rate up to as high as 35, that is the step in the algorithm that we can increase the tidal volume in 1 cc increments as per ARDSnet. So try to get the pH near 7.30. If we find that the pH is still too low after increasing the respiratory rate as high as 35, then we then can increase the tidal volume in 1 cc increments. What oxygenation level do we target in ARDS? Well, we know that in all critically ill patients, we want to avoid both severe hypoxemia as well as hyperoxia. And historically, ARDSnet had guided us to target a PaO2 between 55 and 80, although this had never been rigorously tested. Until last week in the New England Journal of Medicine, a landmark trial called the LOCO-2 trial looked at conservative versus liberal oxygenation targets. And while there was no significant mortality difference, they saw in the conservative oxygenation group that a signal for higher mortality was observed with a low PaO2 as low as 55 in the trial. And so as a result of this more recent data, probably the ideal target for the PaO2 is in the range of 60 to 90 with a SAT of 92 to 96%. We utilize PEEP in ARDS both to improve oxygenation but also to stabilize the lung. It really does prevent the cyclical collapse of the alveoli, particularly during expiration, where an elevated positive end expiratory pressure can maintain that alveoli in the open position. How do we titrate PEEP? Well, one approach, and probably the most common approach, is to use the traditional ARDSnet tables where you can select based on your FiO2 the appropriate PEEP level. There's two different tables, the low PEEP and the high PEEP. There's no mortality difference between the two. And you simply select your PEEP based on the FiO2 that your patient is requiring in order to keep that PaO2 in the range of 60 to 90. Another approach that more recently, another approach that can be utilized to titrate PEEP is utilizing the driving pressure. In 2015, Amato studied driving pressure in order to quantify the functional lung size in ARDS based on the compliance of the respiratory system rather than just the predicted body weight. Because as we know, the actual functional lung size of the lung that we're ventilating is much smaller than the entire lung. And so you can see that by using the relationship where the driving pressure is a ratio of the tidal volume over the compliance, he then was able to quantify that functional lung size. And what he found was that driving pressure was actually most predictive of mortality in ARDS. And so to calculate driving pressure, you simply subtract the PEEP from the plateau pressure. And so one approach can be you set that tidal volume at 6 cc's per kilo, you measure the plateau pressure and make sure it's under 30 centimeters of water, and then you can sequentially increase the PEEP in 2 to 3 centimeters of water increments, measuring your plateau pressure at every PEEP level. And you then want to select the PEEP level where you have the lowest driving pressure. And ideally you want that number under 15 centimeters of water. Once you find that by addition of PEEP, you're exponentially increasing your driving pressure, you want to go back down to that PEEP level where you had the lowest driving pressure. So what is the next step if you've done these methods of mechanical ventilation and yet you still have a patient with refractory hypoxemia? There are a couple of pharmacologic interventions that can be employed. One is neuromuscular blockade. There is some conflict in the literature whether this truly lowers mortality, but in these ARDS patients where we're limiting tidal volume, we find that they can become asynchronous with the ventilator, and using cisatracurium in that setting can really improve both ventilation and oxygenation. Also, inhaled pulmonary vasodilators can be employed, and we typically use inhaled epoprostenol here at Cooper. And then finally, beyond pharmacologic interventions, prone positioning has been shown in the PROSEVA trial to actually lower mortality in those patients that have severe ARDS. Now, prone positioning was first performed in the 1970s as a rescue maneuver for severe hypoxemia, because we find that as you flip someone to the prone position, you are now selectively perfusing those anterior lung units that are more aerated. And so you improve VQ matching and you improve oxygenation. Well, the PROSEVA trial showed that in severe ARDS patients, this also provides a mortality benefit. So this is certainly something that we employ in patients with severe ARDS with a PF under 150. And then finally, the last line of rescue therapy for both severe hypoxemia or acidosis would be VV ECMO. Now, to date, no trial has definitively established a mortality benefit, but this has been limited both by heterogeneous ventilation strategies as well as crossover to the ECMO group in randomized controlled trials. And so while we know that transfer to an ECMO center is associated with improvement in mortality, many patients in that CSER trial did not receive ECMO. And while the Aeolia trial was designed to compare early ECMO versus conventional mechanical ventilation alone, it was controversially stopped early for futility. And even though there was a trend towards improvement in mortality in the ECMO group, it was not powered to definitively demonstrate that. Moreover, a very large proportion of patients in the control group were crossed over to ECMO, about 28%, and it made it very difficult then to evaluate that primary outcome. And so ultimately, what we do here at Cooper and what's largely done nationally is that we utilize ECMO, we reserve ECMO for patients whose life-threatening hypoxemia or respiratory acidosis persists despite lung protective ventilation, paralysis, and prone positioning. As far as other therapies, there may be a role of steroids to shorten duration of mechanical ventilation. We do know that based on the FACT trial that patients that have conservative fluid strategy do better than liberal fluids, and so utilizing conservative fluid strategy and diuresis to target a negative fluid balance is associated with the shorter duration of mechanical ventilation. So just to recap, the most important thing to do is to make sure that your ventilator settings are lung protective, meaning a tidal volume of 6 cc's per kilo of ideal body weight based on height or less, making sure that that plateau pressure is under 30 centimeters of water. Ideally, the driving pressure that you calculate by subtracting your peak from your plateau should be under 15 centimeters of water. We do want to target a pH between 7.3 and 7.45, but we will be permissive with hypercapnia and really allow the PCO2 to rise to as high as 60 or above, as long as that pH stays above 7.15. We can increase the respiratory rate to augment CO2 clearance if we find that a patient is becoming acidemic. As far as oxygenation, we would like to target that 60 to 90 PaO2, which would be about a SAT of 92 to 96, avoiding both severe hypoxemia and hyperoxia. And then finally, we discussed some strategies for that patient with refractory hypoxemia.
Hello, let's have a quick discussion on obstructive lung disease, the maintenance, the treatment of an acute exacerbation, and how we manage these patients in the ICU. So basic definitions just to start. Asthma and COPD are both classified as obstructive lung diseases. Asthma is more of a disease process involving inflammation, mucus production, and a hyperresponsiveness of the mucus secreting cells of the airway to some sort of irritant or stimulus that causes both the bronchoconstriction and the mucus production. If allowed to persist for hours to days, that's when we go more from the hyper-responsive wall to the production of mucus within the airways. COPD, on the other hand, is more of a chronic process, most commonly caused by chronic tobacco use that leads to the destruction of the small airways, a more chronic mucus production, and then the destruction of the terminal alveoli in the airway, which is more classically known as emphysema. COPD can be broken down into the chronic bronchitis, which is more of the inflammation and the excess mucus production with daily production of mucus, and the emphysema, which is more of the just destruction of the air sacs of the lung, the alveoli, which can lead to difficulties with gas exchange. Listed in this slide are 4 different trials, which is how we guide our treatment for COPD. The TORCH trial, 2007, discussing the use of inhaled corticosteroid and long-acting beta agonists. In 2008, the UPLIFT trial, talking about the use of muscarinic antagonists. In 2008, the INSPIRE trial, talking about the comparison between salmeterol fluticasone versus tiotropium for COPD, and then the FULFILL trial published in 2018, talking about the use of all 3 agents together for patients with COPD. Chronic maintenance therapy. For asthma, the main agent that we use for chronic therapy is the inhaled corticosteroid. If we think back at the physiology as to what asthma is triggered by, it's an irritant causing both bronchoconstriction and inflammation / mucus production. The inhaled corticosteroid helps treat that inflammation. The second agent that we add onto it is the long-acting beta agonist, which helps with relaxation of that airway. And as listed in the slide, we have additional medications like glucotriene inhibitors, antihistamines, which both act to help with the allergic response, and then the injectable medications, which can act directly on mast cell activation. They can act directly on interleukins. For COPD, based on the trials that we were discussed previously, the agent of choice to start treatment is the long-acting muscarinic antagonist. It helps with both mucus production and it does help relax the airways. And in people who continue to have symptoms despite that first agent, that's when we start acting the long-acting beta agonists. And additional agents on top of that, we add a steroid, although there is a increased risk of development of pneumonia with the addition of steroids in the COPD patients. We can add on additional agents such as roflumilast or chronic azithromycin, which we will talk about in the exacerbation slide. Let's talk about exacerbations. So definitions. For asthma, exacerbations can be split into moderate or severe exacerbations. Severe means that you need either oral or IV steroids, or you need to be hospitalized in order to treat your exacerbation. Those are that's the definition of severe. Moderate is the need for a step up in your medication, whether that means you're on an inhaled steroid at baseline and they needed to go up on it for a period of time. That's moderate exacerbation, whether you're on an inhaled steroid and they needed to add another agent, or if you're on a combination inhaled steroid long-acting beta agonist and then there's the addition of a third agent, that would qualify as moderate as well. COPD is more delineated by the GOLD criteria, which defines an exacerbation as an increase in dyspnea, sputum production, or change in sputum quality. The two trials listed below, the one on the left from July of 1983, is what initially guided the use of every 6-hour dosing of steroids in the setting of a severe asthma exacerbation, specifically in those with status asthmaticus requiring ICU. The trial on the right is the reduced trial published in JAMA in 2013. That is what has guided us in COPD to say that 5 days of steroids, of once daily steroids, is as good as a 14-day taper in those who have an exacerbation. So, management of the exacerbations. We transition pretty much all forms of meds to the nebulized forms. It's easier delivery, especially when someone has a really tight airway. It's very hard to get the medications in, have good synchrony with someone who's sick with an inhaler. And so we tend to transition to the nebulized forms of the meds because those tend to do better. Systemic steroids, asthma, as kind of mentioned in the previous slide, we use systemic steroids every 6 hours, medium to high dose, which means anywhere from 40 milligrams to 125 milligrams when someone acutely presents in the emergency room. COPD, once daily, 40 milligrams, 5 days, that's what the strongest evidence supports. In some patients, sometimes we will extend it out further if they seem to be having some refractory symptoms by day 5. There are additional supportive treatments we can use as azithromycin for COPD that is shown to have some reduction of inflammatory components, and then supplemental O2 helping with clearance of secretions, etc. Let's quickly touch on respiratory failure. So respiratory failure, we can't talk about that without looking at our good old friend the ABG. There's two main types of respiratory failure: the hypoxemic, where your PaO2 is less than 60 millimeters of mercury, and if you look at a ventilator, the main things that affect that are the PEEP and the inhaled concentration of oxygen, which is the FiO2. Hypercapnic respiratory failure, which is an elevation in the carbon dioxide in the blood, resulting in a drop in pH. And those are affected by the minute ventilation, which is controlled by respiratory rate and tidal volume. There are states where patients will have kind of a mixed picture, or it will have components of both. And so adjustments will need to be made to all 4 parameters in order to optimize the patient based on the ABG findings. Let's talk about hypoxemia and causes. So the 5 main causes of hypoxemia: low P-bar, so low inspired oxygen. Think about being high on a mountain, lower partial pressure of oxygen leading to a lower overall oxygen concentration within the blood. Hypoventilation, a crowding out of the oxygen molecules in the alveoli due to a higher concentration of carbon dioxide molecules. VQ mismatch, where there is a difference in the amount of either ventilation for the amount of perfusion within a part of the lung, or a change in the amount of perfusion per the amount of ventilation within the lung. A shunt, which is no blood going to an alveolus that is having gas go in and out of it, and then a diffusion defect, which is what we commonly see in COPD, in emphysema with the destruction of the alveolar membrane and thickening of the interstitium, where gas has more difficulty kind of exchanging across this membrane into the blood vessel. This slide is taken directly from the FCCS, but talks of hypercapnia. So what causes hypercapnia is if the minute ventilation in your airway goes down, as we talked about, those are controlled by the respiratory rate and the tidal volume on the ventilator. Any and all of these can lead to it. Classically, what happens in the obstructed airway is that you have difficulty kind of ventilating because you develop an overabundance of dead space, and the creation of autopeep, which we'll talk about in the next slide here. Let's talk about autopeep. So autopeep is progressively worsening air trapping in the setting of obstructive airway disease because you're unable to fully exhale a breath. The graphic depicted below kind of shows what normal lungs do, and then the dynamic hyperinflation seen in airway obstruction. So with the laser pointer here, we can see someone take a normal breath, inspiration, expiration, inspiration, expiration. They have the full time necessary to inhale fully and exhale. Whereas in those with obstructive disease, they are unable to completely exhale the volume that they take in due to the tightening of the airways, and so at the end of their expiratory, they don't complete their expiratory cycle, so by the time a new inspiratory cycle starts, you still have air left over that every breath you fail to empty completely. Over time, this leads to what's known as dynamic hyperinflation and the creation of autopeep. That is further depicted here in this image showing the three ventilator waveforms. On the bottom here, you can see, similar to the image on the previous slide, is the depiction of the volume with each consecutive breath. When someone does not have a complete exhalation, the volume continues to go up. The flow, we see that inspiration, expiration, they don't kind of achieve this baseline equilibrium back to zero in the flow rate, which is the development of incomplete emptying or gas trapping. And then with the pressure curves, this is the intrinsic peep or the development of autopeep. We see that for every consecutive breath. Because we have incomplete emptying, the pressure will continue to go up and up and up within the lungs, which is this development of autopeep. How we treat this, we treat the underlying obstruction. That is the use of bronchodilators, the use of steroids. Sometimes when someone is having a lot of autopeep, we need to disconnect them from the ventilator, allow a full exhalation to take place before connecting them back on, and then continuing to troubleshoot the underlying problem. If this is something that is detected, obviously further discussion with your critical care colleagues or your pulmonary colleagues to see how to best optimize the patient on the ventilator is something that would be advised. Paralytics in the setting of obstructive lung disease are useful when someone is having acute worsening in their respiratory status, driven by worsening vent asynchrony that is not alleviated by other measures, continued elevations of airway pressure refractory to nebulized treatments, and other complicating factors that can be alleviated by paralyzing the patient. However, there is no true mortality benefit associated with this. In fact, going as far back as 1996 with Leatherman and 2001 with the article published by ADNET in Intensive Care Medicine, we see that there is a higher incidence of side effects with neuromuscular blockade and steroids, as most of these patients are on steroids, up to a third of patients, and ADNET showing that truly, if we continue paralytics in patients with obstructive lung disease, this is in asthmatic patients of greater than 12 hours, they actually have a higher overall mortality. And so kind of the general thought process behind paralytics in the ICU patients in obstructive lung diseases, we use it when it's absolutely necessary. We try not to use it for a prolonged period of time, which is a little bit different from how we think about paralytics in the ARDS patient, which will be discussed in a different lecture.
Hi, my name is Nitin Puri, one of the heads of critical care medicine. I'm going to give a brief review of upper GI bleeding. The general concept of upper GI bleeding is important upper GI bleeding is that which results in the need for a red blood cell transfusion or hemodynamic instability. Obviously, it's also important if the patient's vomiting blood and you need to be able to secure their airway, but this is just the way we define it in the intensive care unit. The majority of the upper GI bleeds that we get in the intensive care unit are secondary to peptic ulcer disease. That incidence has gone down tremendously with the advancements in endoscopic care, GI care, and the use of PPIs and H2 blockers in the general population. We do see a significant amount of variceal bleeding. When we see variceal bleeding, it's usually a cirrhotic. Also, once the bleeding's been secured, approximately 7 to 15% or 16% of the time, we see rebleeding, which is important, and you have to be aware of that. And you'll have to speak to your gastroenterology colleagues as to who is a high risk of rebleeding after they've done the endoscopy. So important to have good communication with them. These patients usually do well. The mortality is anywhere between 3 and 10%. But when somebody comes in with an upper GI bleed, most of the time we expect for them to be able to leave the intensive care unit and do just fine. So what is our general approach to upper GI bleeding? First, you should take a good history. Make sure you ask about melena. Recognize that patients, if they're tachycardic or the hemoglobin's less than 8, that they're triaged into a more severe category. Also, during that time when you're having that history, hopefully your nurse or you are putting in 2 large bore IVs, 16 gauge or larger. Oftentimes people end up with 18 gauges. A cordis as necessary. But remember, a central line's not a large bore IV access. The width of the catheter, because when somebody has a massive bleed, you want to be able to transfuse quickly, and you need a wider catheter to be able to transfuse quickly. The patient should be hooked up to the monitor, have cardiopulmonary monitoring. Definitely ask if the patient's on any anticoagulants, the direct oral anticoagulants or the novel oral anticoagulants, Coumadin, Plavix, aspirin, etc., Brilinta. At that point, you should start your fluid resuscitation. You also should order blood, and you should make the effort to reverse the patient's coagulopathy, as previously stated. You should start a PPI drip. If a patient's a cirrhotic or you're suspicious for them being a cirrhotic, you should start octreotide. There's a plus minus here about TXA. The data is not supportive of using TXA in patients who are getting endoscopy and are on a PPI. That being said, it's always a conversation you can have with your gastroenterologist if you feel like you think it could be useful. That is not our routine practice. If the patient is stable, then you can get an endoscopy within 12 to 24 hours. And then, from there, the gastroenterologist will triage it as to whether the patient has what type of disease, peptic ulcers, varices, gastric varices, or something else, or esophagitis. If the patient is unstable, you should continue to resuscitate the patient, use vasopressors, then this conversation about TXA could come in, or surgical IR consultation. Also, while we're talking about reversing anticoagulation, there's a conversation about Kcentra. If you have a life-threatening bleed, Kcentra would be the reversal agent of choice for us at Cooper. Would recommend that is what would be used. And how do you define a life-threatening bleed? I would define a life-threatening bleed as patient with hemodynamic instability, and then you transfuse blood and they continue to bleed and be unstable, then that would be a clear indication for Kcentra. You do not need to wait for the hemoglobin to come back. Of course, Kcentra is not going to work unless the patient has a coagulopathy that needs to be reversed. And so that's important. So then if the patient's unstable on the left side of this graph, you do an endoscopic intervention. Patients continue to be resuscitated, likely will be intubated. If you don't find the source of bleeding or the source of bleeding can't be controlled, if your surgical colleagues involved, you might need to speak to interventional radiology to have a plan. Also, if the patient continues to bleed and hasn't been able to control endoscopically, you may consider a Blakemore tube, and I'll get into that a little bit more as time goes on. The initial orders, this is, again, we don't have an order set at Cooper, but type in screen, keep the patient NPO, order your IV fluids. There's no real clear data to support the use of an NG tube. That's essentially a pretty large practice shift over the last decade. I think the only reason to use an NG tube at this point is to clear some of the clots, so the endoscopist could have a clear view. You would use erythromycin to also clear the stomach of clots, so the endoscopist could get a clear view. No clear indication for Foley on these patients. Ordering serial CBCs are important, but also not in the initial resuscitation phase, not seeing that the patient has a hemoglobin 8 while they're vomiting blood and saying, okay, I'm not going to transfuse. You would transfuse that patient because it's going to take a while for the hemoglobin to equilibrate. Calling a GI consult, calling the family, obviously in this moment of crisis, our families are not able to be in the hospital, be with their loved ones, making sure that they're aware of what's going on. I put Foley again, I apologize for that. Holding DVT prophylaxis, putting the patient on the PPI drip. The literature says you could use Protonix BID, our gastroenterologist preferred drips, so if that's what they want, we'll continue to do that. Erythromycin I spoke about. After somebody gets about 6 units of blood, you'll need to monitor their calcium. Now, if they're an upper GI bleed and they're cirrhotic, we give ceftriaxone routinely. And just even with all upper GI bleeds now, if they're going to be admitted to the ICU, they end up getting an antibiotic, and we figure out that they're not a cirrhotic, we may take it off. The workup, also, if you suspect varices, we need to get an abdominal ultrasound with Doppler to rule out portal vein thrombosis, to evaluate the hepatic vasculature, the portal venous system for portal hypertension. So not all patients get intubated. This is controversial. 200 patients were randomized at Cleveland Clinic. Intubated patients had worse outcomes. This 2017 study. Those patients had more complications. So some patients will need to be intubated. It should be a conversation between you and the gastroenterologist. But if the patient's unable to protect their airway because they're vomiting so much blood, or the first time they vomited blood, and you're worried about them doing it again, not being able to protect their airway, then please intubate them. That is by definition a high-risk intubation. You should have 2 suctions, and if you're able to place an NG tube to empty out the stomach, that would be something to consider. Obviously, it's dangerous to place an NG tube in somebody who has esophageal varices. What number do you resuscitate people to a hemoglobin of 7? Here's a good trial from 2013, which set the gold standard that the patients who are resuscitated to a hemoglobin of 9 had worse overall survival at 45 days as opposed to those resuscitated hemoglobin of 7. There are specific considerations. Patients with coronary artery disease, you could consider resuscitating to 8, or patients with active ischemia. Transfuse hemodynamically unstable patients, transfuse 1 to 1 to 1. Again, don't wait for the hemoglobin to come back, and reverse coagulopathy. You can use vitamin K, FFP, or if a patient's acutely unstable and bleeding, you can use Kcentra. Um, it's important to have an algorithm for variceal bleeding. Resuscitate the patient, put them on octreotide, antibiotics, and then endoscopical intervention. If the patient continues to have recurrent bleeding, they'll need balloon tamponade, placing a Blakemore tube. That's our colleague Taryn Trott who did that the other day on his specialized skill set. Post-endoscopy, hopefully the patient stabilizes. You'll have a conversation with GI about how long you want to keep the patient in the unit, what's needed for them. But if the patient rebleeds, obviously call GI back again, continue to get serial hemoglobins. And if post-endoscopy the patient's unstable, they may need a Blakemore, IR intervention, or surgical intervention. The take-home points for this is make sure you establish IV access, don't automatically intubate, transfuse the right amount. Remember, transfuse to hemoglobin of 7 if the patient's hemodynamically stable. If the patient's not hemodynamically stable, you're not necessarily transfusing to a number, you're transfusing to hemodynamic stability, and then follow serial hemoglobins. If they have coronary artery disease, it's all right to transfuse to a higher goal. Work for GI for dispositions on those patients. Post-endoscopy, the endoscopy will give you a lot of information. And stay safe and wash your hands always. Thank you for helping us out, and you take care.
Bye-bye. My name is Sharad Patel. I'm one of the intensivists. Background in nephrology. I will be doing a quick primer on AKI CRRT in the setting of the critically ill. So, most of us know the RIFO criteria. They know the AKIN criteria, which are criteria for AKI. They have been combined in the past few years, and now we have the KDIGO criteria. You have 3 stages, a creatinine-based and then a urine output-based. So obviously you'll see the urine output-based before you'll see the creatinine raise. The kinetics of creatinine, I would really highly emphasize, are important to understand, because if you see a rise in creatinine, most likely you have an injury that occurred 24 to 36 hours ago. So you may have missed the boat already, but it's when you see the rise in creatinine, you need to look what happened 24 hours ago, and try to identify potential nephrotoxic agents, medications, hypotension, contrast, low contrast, where finding is not as strong a culprit for AKI as we used to think, but that's a topic for another day. The criteria for the creatinine, note the 0.3 rise within 48 hours, or the 1.5 to 1.9 times above baseline within a week. So, and that's stage 1. What I really emphasize here is that creatinine is dependent on muscle mass. So let's take the 0.3 rise within 48 hours. If you have a little old lady at 50 kgs and you see that the creatinine rose 0.2 over 48 hours and her baseline creatinine is 0.5. A rise from 0.5 to 0.7 is a large percentage change for this patient. So that is a much bigger drop in GFR than someone who has a baseline creatinine of 1.3 and it rises to 1.6. So that is AKI, but based on KDIGO, it wouldn't be classified as such. So understanding creatinine, that it's muscle mass based, and the kinetics of it's very important in managing AKI. So then you get the advanced stages as well, stage 1, stage 2, stage 3. At stage 2, stage 3, you need to be thinking about RRT moving forward. I am a proponent of really thinking 1 to 2 steps ahead of preparing someone. If you see that the delta in creatinine is large, potassium starting to rise, the patient starting to look volume overloaded, we really need to consult nephrology during this time, or the intensivists, and have a multidisciplinary approach on the timing of dialysis. Is there something that we can stop or prevent now to avoid further AKI and progression of the AKI? But early planning is important, especially in someone who's potassium is rising. I think it's safer for the patient if you have a rise in creatinine from 3.5 to 5 in 24 hours, a rise in potassium from 3.5 to 5 in 24 hours, and now the patient's oliguric or anuric and not diuretic responsive, you should probably be planning to start dialysis soon if you have no major reversible cause like obstructive nephropathy, which you can easily place a Foley for. Why is this important? So AKI is a modifiable risk factor, and as you can see, mortality shoots up if you look at the Kaplan-Meier survival rates. So in people who have AKI and early sustained reversibility, their outcomes are better over time, even looking at a year down the line. But in patients who never recover and don't reverse or require dialysis, their outcomes are poor, and your mortality can worsen up to 50 to 75% in the critically ill in the ICU. And the physiologic reason for that is actually multifold. When you have AKI, one, there's a volume component, so volume overload becomes a risk, and there's a lot of cross interaction. Like if you have baseline compensated heart failure, you may go into decompensated heart failure with cardiorenal physiology. There's increased capillary leak. There's a pulmonary renal syndrome that's not any of the ANCAs. It's just you get more capillary leak and you're more predisposed to pulmonary edema and ARDS type physiology. So it's a multifold reason for progression of AKI leading to other types of multi-organ failure. This slide has kind of been taught over the years, and this is kind of the schema that most people have. So just to walk through this again, if you have AKI, these are kind of the three ways that you break it down: pre-renal, intrinsic, post-renal. I honestly think this is a little dated, but it's a topic for another day as well. But the point of emphasis is that there's a misconception that if someone is pre-renal, we automatically assume that they're hypovolemic, and that's not true. Pre-renal just means an effective low circulating volume state. So through vasodilatation, through HRS, or a low cardiac output state from a weak pump and congestive heart failure. This is also pre-renal. Now, in that latter physiology in heart failure, volume will actually worsen the AKI, and this patient may have venous congestion. So this pre-renal is many different things. You can, in the cardiorenal physiology, diuresing this patient will likely improve their renal function if they haven't had a prolonged state and they haven't progressed to ATN already. So this distinction is important because I think we jump to hypovolemia automatically, and I think this can lead to worsened outcomes in patients who aren't the classic hypovolemic type, and they might be along the lines of the CHF or HRS. Intrinsic glomerulonephritis, this is rare but present. If you have a UA and you have an active sediment, pyuria, hematuria, and it's persistent, you may want to consider that, and a urine microscopy would be important. And I would probably consider consulting nephrology at that point. ATN is probably overdiagnosed and overused. So in sepsis, most often we throw out there that this is ATN. In actuality, if this is new and recent AKI and the sepsis hasn't been prolonged yet, this is actually a hyperdynamic high output blood flow state where your creatinine is rising, but it's not because the tubules are injured yet. It's because the blood is being shunted. The afferent arterial vasodilates, but the efferent arterial vasodilates even more. So your GFR will drop. So it's not automatically ATN if you have sepsis. You obviously want to optimize the hemodynamics, but it's ATN is kind of, I think it's overdiagnosed. To really diagnose this is where urine microscopy is really important, and actually really changes management. So I would order a urine microscopy, and if the renal function is worsening rapidly, consult nephrology for doing a manual urine microscopy, because if there's muddy brown casts, it really changes management in the sense that you probably wouldn't be wanting to overload them with more fluids, because essentially now it's a spigot that's completely closed, and you're putting volume in and now it has nowhere to go. So there will be no urine output, and you just have to wait for recovery by getting rid of the initial insult. So for example, if it is prolonged sepsis and hemodynamic instability, vasopressors to maintain a MAP greater than 65. And then AIN, probably also, this is probably underdiagnosed, but it's hard to diagnose. So if there's persistent pyuria, eosinophilia is what's taught, but eosinophilia is not very specific to AIN. So it's when it's present, you might consider it if there's eosinophilia, but just pyuria by itself, negative cultures, urine cultures, and the right context, for example, persistent penicillins or antibiotics, you would want to consider AIN. Post-renal, please be vigilant about this. If you have a 70-year-old gentleman, you have a large delta in creatinine, potassium shoots up, please at least get a bladder scan, or if you're savvy with ultrasound, put the probe on the bladder, see if there's obstruction. Straight cath would be necessary, and maybe even a Foley and urology consult. This is a can't miss because it's modifiable. Lab workup, I've mentioned a few things. So an oliguric AKI, FeNA can be helpful. So when it's intermediate to high, it's kind of inconclusive, but when it's low, it's helpful. So if you have someone with oliguric AKI and the FeNA is low, that's pointing towards a pre-renal state. And remember, this could be heart failure, hepatorenal syndrome, or hypovolemia. If you put an ultrasound on, if you're savvy with ultrasound, if you have dilated IVC, this is a sign of venous congestion, and this points more towards a cardiorenal physiology, and diuresis might be helpful. But automatically, please do not assume that this is hypovolemia. Obviously, volume challenge is okay, but I would not perform repeated experiments if the creatinine is rising. And if the creatinine is rising and it's rising despite your initial fluid resuscitation. So please be judicious about fluid, because fluid overload is just as bad in AKI as hypovolemia is. Urea, helpful if on diuretics. Urine microscopy, very, very important. I cannot emphasize this enough. But obviously I mentioned muddy brown cast for ATN really changes management, because now you, again, as I mentioned, you have a closed spigot. The RBC, WC cast for GN, and then cirrhosis. Hepatorenal syndrome is thrown around a lot. I think it's more of I think it's on the differential more than it's present. Its base rate really isn't that high. So if you have someone who's cirrhotic and they have AKI, it doesn't mean it's automatically hepatorenal syndrome. So the algorithm you want to go in that point is you have someone with cirrhosis, you have AKI, you can check a urine microscopy if there's active sediment like hematuria, pyuria. Consider doing a urine microscopy, see if there's CAS. IgA nephropathy is relatively common in cirrhotics. If their FeNA is low, it points more towards, my differential is now a little higher for hepatorenal syndrome, but they warrant a volume challenge or an albumin challenge, 48-hour albumin challenge, to rule out hypovolemia, because it is really common in cirrhotics. They're on lactulose, they're getting paracentesis, PO intake really isn't that high often. So this is why you do the albumin challenge in this situation. If the FeNA is low, you've done the 40-hour albumin challenge, you do a urinalysis, microscopic urinalysis, there's no muddy brown cast, there's no active sediment. Now HRS is higher on your differential. Other management pearls, I've mentioned a few things already. I would work on getting at least an IVC. I think it's really helpful, especially in setting a low FeNA. If you have a low FeNA, dilated IVC, consider cardiorenal, and please be judicious with fluids after that, because as you can worsen AKI with that. If you have small collapsing IVC, and CVP IVC is probably one of the most misinterpreted studies, but again, that's a lecture for another day. If it's small and collapsing, at least you can say the patient is tolerant to fluid, and you can try a volume challenge to see if they have an increase in urine output. And then the next day, see if there's improvements in creatinine. FeNA is high again. It can be inconclusive, but you have muddy brown. If you have muddy brown cast, consider ATN. If your potassium is shooting up, your acidemia is worsening rapidly, and volume overload, I would consider a Lasix challenge test. And this is main thing you want to, if you're thinking about the Lasix test, this is one of the most useful things I think that nephrologists and some intensivists do. That's really helpful in really trying to narrow down what the next steps are. So if you have someone with AKI, rapidly rising creatinine, potassium is trending upwards, the patient's acidemic, they've gotten volume, you ensured that the patient has received enough volume that they're at least euvolemic, because if they're hypovolemic, this is not a test you should be doing. But if you think they're euvolemic to hypervolemic based on ultrasound, volume resuscitation, you can do this thing called the Lasix stress test. Basically, you're trying to see if you have any tubules left that are active. So it is 1 mg per kg of Lasix in Lasix naive people and 1.5 mgs per kg in non-Lasix naive people. You give that dose, you look for 200 cc's in the first hour. 200 cc's over 2 hours. Now, greater than that urine output is someone who's a responder to the Lasix. Less than that is a non-responder. And basically what they've seen is that it is predictive of need of RRT. So if you're a responder, a very small percentage ever actually needed dialysis down the line. If you're a non-responder, I would consider talking to nephrology, maybe even placing a dialysis line after you've discussed with nephrology and moving forward RRT. It's a time-saving measure, and you get planned down early. And if they're hyperkalemic and potassium's trending upwards, this is not something that the renal function will be reversing anytime soon. So I would consider starting dialysis on this patient at that point. RRT timing. So we're still not sure what the optimal time is for dialysis. So there's been a few recent trials. The Acute trial says that no major difference between early and late start. Elaine, which I believe was in France, improved mortality with early start. So we're still not sure. And again, these trials by itself in this talk is a lecture in itself. So timing is still not clear, but I think we have to have a nuanced approach to this. If, like I mentioned before, someone has a rapidly rising potassium, they're oliguric, anuric, they're starting to look volume overloaded, oxygen demands are going up, then their Lasix stress test, they're not putting out much urine. This is someone that is outside the realm of what this study. Their pretest for requiring RRT is so high, and their probability of requiring RRT and their potassium rising even more, it's safer to do it in a controlled setting early and discussing and starting RRT appropriately than to not. So I think it's contact specific, and the tool with the Lasix stress test is very helpful, I think, in determining when to start dialysis. Indications, obviously most of us know this. This is hyperkalemia, hypervolemia, uremia. This is a clinical diagnosis, not just based on BUN. You don't get pericardial effusions as much anymore because it's just uremia doesn't last as often without getting dialysis in the modern era, and then refractory acidemia. Please, fluid balance is important. Hypervolemia is just as dangerous as hypovolemia in AKI. So this is just a study by Bouchard et al. Showing that the black is the dialyzed. So people on dialysis, as their fluid balance started going up, their mortality started worsening as well. So if you are on CRRT already, consider having some UF and at least even to negative fluid balances. Why CRT? So there's never been a study to show that CRT is superior to IHD in terms of mortality in all comers. So, but remember is that in these studies, people on 2 vasopressors will probably be excluded. So it's really kind of hard to determine where the benefits of CRT come in that group of patients. So at our center, CRT is readily available. So if you have someone who's on Levofed and they're requiring RRT, CRT is probably the way to go. IHD and everyone else, they are not on vasopressors. If their potassium is rising rapidly, they're hemodynamically stable, IHD is the way to go because your clearance is a lot faster. In 3 to 5 hours, you have a high blood flow, high clearance procedure that you'll be able to get more clearance quickly than you would with CRT. If you're trying to get rid of some like 5 to 10 liters of fluid, someone's really hypervolemic, CRT's probably a little better because over 5 days you can do it continuously throughout the day, whereas IHDs logistically it's a 3 to 5 hour session, and removing a large amount of fluid is difficult. You may get more hemodynamic instability. So we have CRT available. Again, this is a lecture in itself, but pressors consider CRT, hypervolemic consider CRT, otherwise IHD is probably. A little thing about some differences between CRT and hemodialysis. Hemodialysis, a lot higher blood flow, up to 500 milliliters per hour. That's why you may get the hemodynamic instability. Dialysis rate's a lot higher. This is overall why you get so much more clearance than in CRT. CRT, it's 150 to 250. And then there's nuances as far as how you can do fluids and replacement fluids, which we won't go into now. But it's lower blood flow, lower dialysis rate, but continuous throughout the day. Prescription, so hopefully, I doubt that this is something that we'll be doing, but basically CRT prescriptions based on dose, how much dialysate flow you're going to be prescribing. So basically an 80 kg person, you would just do 20 cc's per hour per kg, and you get about 1600. You might want to increase that if they're going to be traveling. So you basically want to get about 1600 this should be over 24 hours, 600 cc's of dialysate over 24 hours, and this is your 24-hour prescription to give them an adequate clearance. And so that's kind of the basic thing. They've looked at high intensity, higher prescriptions, and there's never been shown any benefit to have higher prescriptions over 24 hours. Right.
Okay guys, we're going to hold off on the presentation right now and go straight to a chalk talk on everyone's favorite diagnosis, hyponatremia. Whether you love it or hate it, chances are you're going to need to treat it, because about 15% of all patients admitted to the hospital and managed throughout the hospital are going to carry a diagnosis of hyponatremia. And most likely in the ICU, a large proportion of them are going to be seen by you. Either as a primary diagnosis or a secondary diagnosis. So building a systematic approach to managing hyponatremia, whether it's symptomatic or asymptomatic, is very important. So in order to understand hyponatremia, for this lecture, I need you guys to think about the body in 2 compartments. Compartment number 1, okay, is volume. And compartment number 2 is hydration. Okay? Those of you who've rounded with me know that it's one of my pet peeves when people talk about patients who are volume depleted as being dehydrated and patients who are in fact dehydrated being volume depleted. I need you to separate these 2 compartments and call them for what they really are. Volume is a function of total body solute. Okay, total body solute. Okay, and what is solute? Solute is the number of particles. Okay, and that concentration of solute particles is what holds volume in the intravascular space, right? So when you bolus that liter of normal saline, you're not bolusing the liquid in that bag. You're bolusing the particles in that bag, okay? And that's what's going to facilitate expansion of the intravascular space. So that is volume. Hydration is a function of total body water, okay? All right, and it's important for you to keep these 2 concepts separated, and if you can do that, you can manage hyponatremia, okay? So the first step to managing hyponatremia is to separate your diagnosis of hyponatremia by tonicity and volume status. Many of us gravitate straight towards volume status, but it's important to think about tonicity first, okay? So step number 1 is tonicity. Okay? You have hypertonic, isotonic, and hypotonic hyponatremia. Okay? Tonicity, okay, is the concentration of particles in solution. That solution being total body water, okay? So understanding the tonicity of the body is to understand the amount of total body water. So patients who are hypertonic, okay, have low total body water. Just bear with me here, okay? Patients who are isotonic have even total body water. And patients who are hypotonic, by definition, have high total body water. Take these as true statements and run with them as we build our approach, okay? So examples of hypertonic hyponatremia would be hyperosmolar hyperglycemia. Examples of isotonic hyponatremia are going to be things like hypertriglyceridemia and paraproteinemia. And examples of hypotonic hyponatremia are really going to be everything else. And this is the majority of patients that you're going to see in the hospital, okay? But let's take a step back and think about isotonic hyponatremia, okay? You know, tonicity, very important concept. When you bolus someone with a liter of normal saline, okay? All right, how many milliequivalents of sodium chloride are in that liter of normal saline, right? It's 154 MEQs per liter, okay? When you think about your serum sodium concentration, let's just say I measure yours, it's 143 MEQs per liter, okay? That's normal, all right? So why is normal saline appear hypertonic to your body, all right? And that goes with this concept here of circulating fat and protein, right? 7% of your circulating blood is fat and protein. When I take your blood and I run it through a BMP machine, it doesn't register, okay, what's seen with this 7% circulating fat and protein. So although I run your blood and it's actually 154, it shows up as 143. It's an important concept if you've ever really thought about it, but that's an example of isotonic hyponatremia, okay? Pathologically, you're going to see isotonic hyponatremia in patients with, you know, hypertriglyceridemic induced pancreatitis or high circulating paraproteins like in multiple myeloma. All right, so let's jump down to what matters. Hypotonic hyponatremia, right? Or like we said, by definition, high total body water. Once you figure out that it's hypotonic hyponatremia, you're going to then think about volume status. Okay? So you have hypovolemic hyponatremia, iso or euvolemic, and hypervolemic. So hypervolemic hypotonic hyponatremia, euvolemic hypotonic hyponatremia, and hypovolemic hypotonic hyponatremia. Like we said, treatment strategy only consists of thinking about two compartments, okay? So compartment number one is total body water, and compartment number two is volume or total body solute, okay? Total body water, total body solute, total body water, and total body solute. Okay, so let's talk about some common diagnoses. Hypervolemic hypotonic hyponatremia, commonly patients with cirrhosis, nephrotic syndrome, congestive heart failure. Euvolemic hyponatremia, what we think about most commonly is patients with inappropriate ADH release and any of a billion medications. And hypovolemic hypotonic hyponatremia, patients coming in with solute loss, say through diarrhea or bleeding. Okay? Think about these three states. All right, we already said that they are hypotonic and by definition have high total body water. So total body water high, total body water high, total body water high. Okay? Hypervolemic, so by definition, they have high total body solute, so total body solute high. Euvolemic, by definition, even total body solute is even. Hypovolemic, hypotonic hyponatremia, by definition, has low total body solute. Okay? Now let's talk about how we treat this. Okay? So in patients who are asymptomatic, who present with hypotonic hyponatremia of variable volume status, let's figure out how to treat. So how do we treat a high total body water? We free water restrict. That is treatment number one for this compartment. Okay? How do we treat high total body solute? We give Lasix, right? We give a loop diuretic to the patient and have them diurese out, not liquid, but solute, right? They pee out through the loop of Henle multiple solutes when you give a loop diuretic through that channel, right? And that's why you already understand how to treat hypervolemic, hypotonic hyponatremia, free water restriction, and Lasix, okay? Euvolemic hyponatremia, by definition, has high total body water. So what are we going to do? We're going to free water restrict. Treatment for compartment number one. Euvolemic hyponatremia has normal or even total body solute. So what are we going to do? Give normal saline? No. We're going to do nothing. Okay? This is something that we're going to talk about in troubleshooting because people oftentimes do this incorrectly. So the only treatment for asymptomatic hypotonic euvolemic hyponatremia is free water restriction. Hypovolemic hypotonic hyponatremia, by definition, have high total body water. So what are we going to do? We're going to free water restrict. And by definition, they have low total body solute. So what are we going to do? We're going to give them the particles in that bag we talked about. So we're going to give them normal saline, okay? And that will replenish the particles lost. Now you're going to ask me, you're going to free water restrict somebody who comes in hypovolemic? The answer is yes, because by definition, they have high total body water, but they're solute depleted. So if you allow them to drink, right, they're not going to improve their hyponatremia, okay, because they're going to continue to contribute to their hypotonic status, right? You have to free water restrict and give them back solute, and you will see that sodium correction, all right? Very important concepts here. This is how we're going to build our approach to asymptomatic hyponatremia. Now let's talk a little bit about some troubleshooting scenarios. Okay guys, now we're back with some troubleshooting. Troubleshooting scenario number one is going to be asymptomatic SIADH, right? Or what we said by definition, right? It's hypotonic euvolemic hyponatremia, right? Or high total body water and even total body solute, okay? So our treatment for this patient is free water restriction only, okay? So you may ask yourself, well, why don't I just give them normal saline? And this troubleshooting scenario is to help you understand why giving normal saline to a true SIADH patient could potentially be harmful, all right? So let's remember that your kidney, all right, is smarter than you are, all right? And here in the collecting duct, right, in response to inappropriate ADH release, you're going to have an increase in everyone's favorite USMLE scenario, an increase in aquaporin channels, right, in response to inappropriate ADH release. And those aquaporin channels are going to increase the concentrating ability of the kidney, right? So if you look at a patient who has SIADH, take a look at that urine osmolality, okay? So urine comes in, gets concentrated down, all right, and then you pee out concentrated urine. So for the sake of math, and you'll often see this, let's say that this patient has a urine concentration of 616 milliosms per liter, okay? That is the urine osmolality that you see, okay? And that is the kidney's concentrating ability. So if you give them a liter of normal saline to fix the problem, and by definition doing the wrong therapy, what's going to happen to their serum sodium, okay? So remember what we said, 1 liter of normal saline has 154 MEQs per liter, right? The osmolality is 2 times that, which 2 times 154 ends up being 308 milliosms per liter, okay? There's the osmolality of the normal saline, all right? So let's go ahead and give that normal saline. Like I said, the concentrating ability of the kidney is intact, right? So how do you take 308 milliosms per liter and turn it into 616 milliosms per liter? It's just a matter of dealing in concentrations. So 308 milliosms per liter is the same thing as 616 milliosms in 500 mLs. Simple math, okay? So you now can pee out 500 mLs of the concentrating ability of the kidney. So what's left over in that bag of fluid that you gave? So 500 mLs of concentrated urine goes out, and then you're left with 500 mLs of straight up water, okay? And that 500 mLs of water is then reabsorbed into the body, okay? And by giving someone normal saline who's a true inappropriate ADH responder, you can in fact continue to drop their sodium, okay? So an important troubleshooting concept in someone with asymptomatic euvolemic hypotonic hyponatremia, that normal saline, so by giving them solute at a level of less concentration than the concentrating ability of the kidney, will result in an increase in free water retention and a drop in their serum sodium. Okay, all right, so we're back with troubleshooting scenario number 2. You have a patient who has a serum sodium of 119 milliequivalents per liter, and they have mild to moderate symptoms, okay? So the first thing you need to ask yourself, okay, in this situation, all right, is what is the duration? Okay, all right, next, what is the severity? And then you can figure out what your treatment strategy is going to be. All right. So it's important to figure out the duration of hyponatremia, because as the cerebral osmostat changes, that's when you worry about the risk of developing osmotic demyelination syndrome, right, or central pontine myelinolysis. All right. And we define acute hyponatremia as hyponatremia occurring within 24 hours. So that would be an acute change. Anything past 24 hours, right, 48 to 72 hours, you're going to have redistribution of that cerebral osmostat, and therefore chronic hyponatremia defined outside of that window. And anybody who has chronic hyponatremia, treating or correcting this hyponatremia too quickly puts them at a high risk for osmotic demyelination syndrome, okay? Especially people who have severe hyponatremia, which is defined as a serum sodium less than 120, all right? So you have to ask yourself, well, what is the appropriate treatment strategy, and what is my risk for osmotic demyelination syndrome? So in somebody who has mild to moderate symptoms, which would be something like nausea or a little bit of confusion, you're obviously going to treat them with hypertonic saline. Common treatment strategies are going to recommend that you treat them with normal saline, starting at 15 to 30 mLs per hour. Now you can do various calculations to try to see what their solute deficit is and then replace based off of that. A lot of those calculations are relatively inaccurate over time. Some tend to underestimate. I think starting with 15 to 30 mLs per hour and serial BMPs will allow you adequate control, taking into consideration whether or not they're high risk for overcorrection quickly, and we're going to talk about that in a second. So your goal change is going to be 4 to 6 MEQs per liter, okay, over 24 hours, okay, not to exceed 8 MEQs, okay, in that 24-hour period. And that would be a safe strategy of treating this patient, all right? Now, patients who are prone to correcting very quickly, all right, and remember, you are also going to free water restrict because they are hypotonic, right? So hypotonic hyponatremia plus mild to moderate symptoms results in free water restriction plus hypertonic saline, if they're in a state that puts them at risk for correcting quickly, you need to think about that up front. All right. So states that place patients at high risk would be patients who are chronic alcoholics with low solute intake, so like your potomania patients, patients who are volume depleted or hypotonic, hypovolemic hyponatremia, who are symptomatic, who you have to replace with hypertonic saline on top of free water restriction. Those patients have a tendency to correct very quickly. One of the strategies that we use, right, to sort of help limit the rate of correction is actually to give them DDAVP. All right. So in patients that you would classify as high risk, all right, the potomania patients specifically I want you to think about, and the hypovolemic hypotonic hyponatremia, treating them with 1 to 2 mics per sub-Q every 8 hours for 24 to 48 hours, along with serial VMPs, may help them hold on to a little additional free water and decrease your rate of correction. Obviously, you're going to titrate your DDAVP need and dose based on your rate of correction, but in those patient populations, we actually start this early oftentimes while we treat, like we did in our previous strategy, substituting hypertonic because they are in fact symptomatic. Troubleshooting scenario number 3 that you may be called to respond to would be a patient who's presenting with hypotonic euvolemic hyponatremia with severe hyponatremia as defined by a serum sodium less than 120 and severe symptoms, meaning vomiting and coma. Okay, and let's make it even more easy. Vomiting, seizure. So this patient is having severe symptoms of vomit, then leading to seizure. Okay. In the setting of severe symptoms, your goal is to make a rate of correction very quickly, okay, in order to abort those symptoms and help to manage the patient. All right. So in the setting of severe symptoms, your goal is to make a change of about 5 to 6 MEQs acutely, despite the fact that this patient most likely, and I'll just say is, chronic. Okay. Your goal is to make this rate of correction in order to prevent further seizures. Okay, how do we do that? Well, we're going to give them 3% saline, okay, in 100 ml infusions over 10 minutes times 3 doses in order to raise this serum sodium concentration by about 5 to 6, okay, and abort severe symptoms. All right, so we've kind of talked about someone who is asymptomatic and how you would treat them. We talked about someone who was symptomatic and how you would treat them, and we talked about symptomatic disease and high risk for osmotic demyelination syndrome. And lastly, we talked about someone who has severe disease and severe symptoms and how we need to acutely change their sodium concentration in order to abort those symptoms, and then we will maintain that total correction of a goal of no more than 6 MEQs over 24 hours, right? So again, free water restriction and acute management with 3%, and this can be repeated until symptoms resolve. Okay, all right. So that's the approach to hyponatremia. Thank you guys very much.
Hi, my name is Chris Potestiel, and this presentation is on thrombocytopenia and transfusion. This will be outlined like other topics in this lecture series. We'll talk about basic theory, the approach to administration of blood products, and troubleshooting. One caveat here is that we'll do this 3 times. We'll do it for each of the major components of whole blood. So we'll talk about plasma, platelets, and red blood cells separately. Although there are some commonalities, they're all given for sort of unique reasons, and so it makes sense to go through them each one by one. Plasma transfusions. When plasma is removed from the whole blood, it's broken up into components. So FFP contains most of your blood products and is given for most coagulopathies. This is because it contains all of the coagulation factors in relatively high concentrations, and it contains high concentrations of factor 7, which is the linchpin of the coagulation system. Sort of precipitated out of the FFP is the 5 factors listed here in the figure. Factor 13, von Willebrand's factor, factor 8, fibronectin, and fibrinogen. The only time we really give cryoprecipitate is to treat diseases that are that cause a loss of those 5 factors. So DIC causes low fibrinogen, von Willebrand's disease causes low or absent von Willebrand's factor, and hemophilia A causes low factor 8. These are the only 3 conditions that I would consider giving cryoprecipitate. To correct any other coagulopathy, I would use FFP. Give approximately 4 units of FFP to correct an acute coagulopathy. It's really hard to decide how many units to give. It's based on how high your INR is and how acute the issue is. If you have a urgent need for reversal, if a patient has an active bleed, active head bleed, life-threatening bleed, you can use concentrated factor 7 or 4-factor PCC. A pharmacist will be able to walk you through the dosing of those medications. This may also be a consideration if a patient will not tolerate a large volume of FFP. Each unit of FFP is approximately 350 cc's. So if you're giving, 4, 8, 12 units, you're talking liters of fluid. And there are certainly patients in the hospital that will not tolerate that much fluid administration. Also to keep in mind, for warfarin reversal specifically, or for nutritional deficit, you should consider vitamin K. Vitamin K is dosed 10 milligrams IV daily for 3 days. This will help sort of in those specific situations because a lack of vitamin K is part of that coagulopathy. Troubleshooting with plasma transfusion, I just want you to keep in mind that FFP has some of the highest incidence of side effects among blood transfusions. FFP has the highest risk of trolley development among all blood products, so you should keep that in mind. It has the highest amount of citrate in all blood products. So citrate toxicity will lead to hypocalcemia. Calcium is an important cofactor for the coagulation cascade, so it actually can work against what you're trying to do here. So for every 3 or 4 units of FFP that you give, I would give a gram of calcium chloride. And don't be shy, you won't give the patient too much calcium, especially if you continue to administer FFP and packed red blood cells. Also keep in mind that the INR of FFP itself is 1.4 or 1.6. There are scenarios where you will have a patient with an INR of 1.5, but the proceduralist feels uncomfortable doing the procedure. This happens sometimes with endoscopies, sometimes with IR procedures. FFP is not your go-to here because it won't fix the INR. So having kind of an honest conversation with the person doing the procedure and considering things like PCC or even just giving vitamin K and waiting a day if that's a viable option may make the INR go below 1.5, but FFP certainly won't. Platelet transfusion. When you're considering platelet transfusion, you should consider the cause of thrombocytopenia first. So many patients in the ICU are thrombocytopenic. This is because platelets are a negative acute phase reactant. So in any inflammatory state, your platelet level will go down. Platelets are sequestered in the spleen. In addition, these patients with long med lists likely have an agent that causes thrombocytopenia on them. Common agents are antibiotics like vancomycin or linezolid specifically, and agents used for GI prophylaxis, so famotidine and pantoprazole. Another topic separately is heparin-induced thrombocytopenia. If your patient is thrombocytopenic and on heparin, you need to consider that diagnosis. Probably a hem-onc consult or look at MD Calc to calculate a 4T score would be appropriate in that scenario with heparin-induced thrombocytopenia. Listed on this slide are the thresholds for when we transfuse patients. All patients should have platelet level above 10, so we give a pack of platelets if your platelet level goes below that. If you're at risk for bleeding, if we're doing line placement or you have minor superficial bleeding, I would consider giving a pack of platelets to keep the platelets above 20. We target platelet level above 50 for most procedures, and a platelet level above 100 for procedures that are at high risk of bleeding, vascular surgery, cardiac surgery, thoracic and neurosurgery. Platelets are given in one single donor platelet pack. This is the equivalent of what used to be called a 6-pack. We now have single donor platelets instead of multi-donor, so that's why the change in nomenclature. You can expect the platelet count to increase by 30 to 50,000. One single donor platelet pack will last about 4 to 8 hours. You have to consider this timing if you're giving the platelets specifically for a procedure. So you can't give platelets today to do a procedure tomorrow because they will have sort of lived through their half-life. You can also consider fibrinolytic therapy like aminocaproic acid and tranexamic acid for patients who are having bleeding despite platelet transfusion or patients who are just quote-unquote oozy from surgery. Things to consider about platelets. Platelets have the highest risk of bacterial contamination because they are stored at room temperature. Platelets should not be transfused through a blood warmer. This will cause them to clump and cluster and dysfunction. ABO compatibility doesn't matter for platelet transfusion because there's no red blood cells administered and no antibodies included in the platelets. Keep in mind that we have the lowest stores of platelets out of all blood products in the blood bank. This is because their shelf life is only 5 days. So give platelets judiciously, especially given the fact that a lot of your ICU patients and a lot of patients in the hospital are thrombocytopenic anyway for reasons that are not, that they don't need urgent platelet transfusion. So please consider the risks and benefits of platelet transfusion. Packed red blood cells are given to improve oxygen delivery to tissues. It's very, very unclear what the appropriate threshold should be. I think as a basic rule of thumb, we should aim for a hemoglobin threshold of 7 in all of our patients, and 8 in certain populations, specifically those with a history of coronary artery disease. There's a lot of literature on this that we don't have time for here, but these numbers you should keep in mind. 1 unit of packed red blood cells will raise your hemoglobin by exactly or around 1 gram. In acute bleeding, you can't use lab values to tailor your resuscitation. The patient will not have time to re-equilibrate, and the hemoglobin is not reflective of their true volume state. So I would just, in acute bleeding, would just try to replace what the estimated blood loss is with packed red blood cells. And I would again recommend 1 gram of calcium for every 4 units of blood product given. Remember the 3 T's, taco, trolley, and trim, transfusion-related immune modulation. These are more relevant with the more blood products. Packed red blood cells are the most common transfusion reaction is a non-hemolytic febrile reaction. The most common reason for serious transfusion reaction is clerical error. And if your patient is hemodynamically stable with no evidence of decreased end organ perfusion, they probably don't need blood.
Hey everyone, this is Chris Knoll. This presentation is meant to be a quick primer on tumor lysis syndrome as it applies to the ICU. So let's jump right into it. So I think we're all pretty well familiar with tumor lysis syndrome itself, but just as a quick refresher, tumor lysis syndrome occurs when we have tumor cells, either solid or liquid, that are rapidly dividing and fragile and end up lysing, or after a patient receives induction chemotherapy, the tumor cells rapidly lyse and release their inner contents. So this can lead to, due to the release of potassium, phosphorus, DNA, to hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia as a result of the phosphorus binding up to calcium. So why does this matter? Other than the electrolyte disturbances that can cause specific pathology, the urate crystals and calcium phosphorus products can end up clogging up the tubules in the kidney and resulting in significant AKI and renal failure, as well as arrhythmia due to the hyperkalemia and seizure due to hypocalcemia. In terms of tumor lysis syndrome, the formal definition, so there's the Cairo-Bishop definition, where they look at 2 out of the following lab criteria if the patient meets within 3 days prior to or 7 days after undergoing induction chemotherapy. And then they also talk about clinical tumor lysis syndrome, which involves laboratory abnormalities above plus one of the 3 clinical criteria that you see there: AKI, cardiac arrhythmia, or a seizure. So in terms of the treatment for tumor lysis syndrome, we're basically aiming at helping to control the various electrolyte abnormalities that you may see, specifically hyperkalemia, hyperphosphatemia, and managing hypocalcemia, usually by helping to regulate the phosphorus levels. But one of the major problems that tends to escalate everything else is the development of these urate crystals that can lead to significant AKI. Most of the therapy that we do is focused on managing the uric acid levels. So in terms of hyperuricemia treatment, there's a number of different ways that we can achieve this. So one is we can try to flush it out with IV fluids. We can try to decrease production with allopurinol, which will show the following slides. We can break it down with respiricase. Obviously we need to manage the other electrolyte abnormalities that are present, and then ultimately if things aren't being managed with the strategies above, the patient may need dialysis. So we've all seen this diagram that shows us what happens with DNA breakdown to purine analogs. They catabolize into various byproducts, ultimately leading down to uric acid. Along the way, allopurinol can block 2 portions of the step and therefore decrease uric acid production. Where respiricase plays a role is that it actually, rather than preventing the production of uric acid, it actually helps to decrease the levels of uric acid to a much more soluble and byproduct that you're able to excrete in the kidneys. So in terms of how we determine which we use for therapy, so when you're inducing someone with chemotherapy, or maybe they have a high-risk tumor, the common way to do this would be to evaluate the patient's risk, risk stratify them, and then come up with a treatment plan based on that. This is mainly preventative, anticipatory in terms of the patient's pathology and treatment plan. You'll note in the high risk, you're really looking towards hydration and management of respiricase. In terms of how you determine whether someone's low, intermediate, or high risk for tumor lysis syndrome, there are published criteria in terms of tumor type, size, extent of the disease that help to determine that, but we won't necessarily go into that here. So what about our patients in the ICU? Are we necessarily risk stratifying them and then coming up with a treatment approach based on that? Possibly, if they're coming down stairs or they're in the ICU for a specific liquid malignancy and undergoing induction chemotherapy, there may be discussion with oncology, hematology. But most of our patients that come to the ICU are there because they've either failed their anticipatory / preventative treatment, or they have significant comorbidities that are limiting simple hydration and other therapies. So often our patients are already in the very high risk category. in terms of tumor lysis syndrome, or they have already full-blown tumor lysis syndrome that we're trying to manage as best we can based on that. So I think, as with most aspects of critical care or emergencies, it's best to keep it quite simple. And so in that light, I've created a simple ICU tumor lysis checklist, which we'll see on the following slide. So what this entails is, essentially, if you have a patient who's in tumor lysis in the ICU, first thing should be to initiate IV fluids for hydration targeting 2 cc's per kg per hour of urine output. Our goal here is to help to maintain renal blood flow, maintain urine output, flush out those urate crystals, flush out the potassium, and all the other byproducts that we want to control in this syndrome. But we should know that if the patient isn't peeing at all, continuing to hit them with fluids is not going to benefit them with respect to their tumor lysis syndrome. Another thing to keep in mind is if their urine output isn't quite adequate, but they're well hydrated, they're not hypovolemic, and we're not dealing with obstructive uropathy, then some diuretics to help to maintain their volume status is just fine. The other treatment the next thing on our checklist is consider allopurinol if our uric acid level is controlled, less than 8 milligrams per deciliter. If not, then you want to move down the checklist to rasburicase. So if the uric acid is greater than or equal to 8 milligrams per deciliter, or let's say they are failing their preventative treatment with uric acid up on the floor and their AKI is worsening, uric acid is climbing, then rasburicase would be our drug of choice. So dosing for this is, for the manufacturers, would be 0.2 milligrams per kg, once daily for up to 5 to 7 days based on the uric acid level and response. Or you can just keep it simple and go with a flat dose of 3 milligrams each dose, not per kg as listed here, sorry. Keep in mind, however, that this is contraindicated in G6PD patients. Next thing on our checklist is going to be to manage the other electrolyte disturbances. Mainly, our most dangerous one is going to be hyperkalemia, and we're all well familiar with how to manage that. Of course, we're going to continue to check our electrolytes, phosphorus and uric acid, every 6 hours in order to target our therapies based on those numbers. We want to involve our nephrology colleagues in these difficult cases, and then, if need be, if all else fails, dialysis with the usual indications that we're all familiar with. So that's all I have, guys. Just a quick primer on tumor lysis syndrome. Here are some resources that I used, and thank you for listening. Hey everyone, it's Chris Knoll. This lecture is meant to be a quick primer on neutropenic sepsis. So given the theme of short, quick lectures, let's get into it. So we're all familiar with this, the definition of neutropenic fever. So essentially it is an absolute neutrophil count of less than 500 cells per micron. Certainly we can talk about different definitions for neutropenia. Less than 1500 is often considered, but less than 500 is when you run into issues with clinically significant infections. So neutropenic fever is going to be an ANC less than 500 and a temperature either one time greater than 38.3 Celsius or 101 Fahrenheit, or sustained greater than equal to 38 degrees Celsius or 100.4 Fahrenheit for 1 hour or more. So why do neutropenic patients end up with neutropenic fever and neutropenic sepsis? So a couple of factors. One is they're immunosuppressed, their neutrophil count is low, but also their neutrophil function is often not very good due to the chemotherapy agents that usually cause this syndrome. The other thing that happens with them is that they end up with mucosal breakdown, which we've all seen mucositis and certainly in the GI tract as well, which can put them at risk for bacterial translocations, fungal translocation of normal colonizing bacteria and fungus. And then certainly most of these patients are undergoing invasive procedures and hospitalization if they are sick, and all of that can lead to clinically significant infection. So what types of pathogens are we worried about in neutropenic sepsis? So bacterial are going to be our primary source of infection, and gram-positive actually more clinically prevalent than gram-negatives. Anaerobes tend to be relatively uncommon as a clinical source of infection in neutropenia. However, you can think of these in areas where you might expect anaerobes for your source of infection. So think like the mouth, think pelvic infections. Fungus, so particularly Candida, so think bloodstream infection or Aspergillus. Certainly if you have a clinical presentation of respiratory illness with pulmonary nodules concerning for this, that might be a clinical presentation. And also, of course, viral illnesses. So particularly of interest here are going to be latent HSV or VZV, which have reactivated. So think oral lesions, think multiple dermatome distribution, shingles. And then certainly don't forget about other common bugs that we see in patients throughout the hospital and the ICU, such as C. diff, influenza, and also keep in mind pneumocystis pneumonia for patients who are undergoing prolonged high-dose steroid treatment, which some of the oncology patients who end up with neutropenia will have as well. So what is our initial management for neutropenic sepsis? So keep it simple. Essentially, we're doing the same things we would do for another septic patient in that we're starting early antibiotics. So the goal here, society recommendations are less than 1 hour. So to get both blood cultures and to start antibiotics, and some experts, certainly try to push for less than 30 minutes. We all know the logistical difficulties with that, but we should aim to get antibiotics on board less than 60 minutes, as this is a true medical emergency. We should focus on fluid resuscitation as we normally would for septic patients, and then think about source control. However, often the neutropenic patients, it's going to be due to bacterial translocation, but certainly keep it in mind. Is there a source of infection that we need to go after and drain, or as we would in any other type of patient? Antimicrobials. So our strategy should be primarily, the backbone is going to be an anti-pseudomonal beta-lactam. So think cefepime or meropenem for all patients. So that's the baseline. If the patient has certain criteria, you're going to also add other antimicrobials. So of particular importance in the critically ill population is going to be MRSA coverage. So add vancomycin if they're critically ill, meaning they're hypotensive, they have altered mental status or whatnot, or if they don't appear that clinically ill, but you suspect certain types of infections, such as catheter infection, skin or soft tissue infection as a source, or pulmonary infection, pneumonia. Also think about adding anaerobic coverage. Often not needed, but think about this if your suspected source of infection is the mouth, sinusitis, perirectal area, which otherwise would form an abscess if they weren't so neutropenic, pelvic abscess, intra-abdominal source of infection, think about typhlitis, and then anaerobic bacteremia if that's proven. So not our primary go-to anaerobic coverage, but if you have a specific source which makes you concerned about anaerobic bacteria, then it's indicated to add. Additionally, we also want to think about antifungals. So typically we don't need to start antifungals up front, but if there's ongoing clinical deterioration despite antibiotic use, or there's persistent fevers after 4 to 7 days of antibiotics without a clearly identified source, think about antifungal coverage. This comes from the fact that it takes about 5 days on average, for neutropenic fever patients to effervesce. And also consider antifungals if you suspect a fungal source such as pulmonary nodules, which may be concerning for aspergillus. Antifungals at Cooper will tend to be mycofungin. This is iconocandin we have on formulary, and this is chosen over fluconazole because it covers some common resistant forms of Candida, notably Candida glabrata and cruzi. And then if you're thinking about an aspergillus infection, think about voriconazole as your agent of choice. So what about granulocyte colony stimulating factors? Is there a role for patients who have neutropenic fever, neutropenic sepsis? So these are not recommended by the ISDA for established fever and neutropenia, but probably worth a discussion with oncology regarding the utility. So in summary, first things first, we want to identify patients with neutropenic sepsis, which we'll do by noting fever plus an absolute neutrophil count less than 500, keeping in mind that fever may be the only symptom that these patients have of a very serious clinical infection. We want to keep it simple, so focusing on early antibiotics, fluid resuscitation, and source control, just like we would with any septic patient. Early antibiotic goal is going to be less than 60 minutes and as soon as possible. The antibiotics coverage we're going to aim for our critically ill patients is going to be cefepime or meropenem to satisfy the anti-subliminal beta-lactam recommendation as the primary antibiotic, and add vancomycin if the patient is critically ill or we suspect soft tissue infection, central line infection, or pneumonia. Think about adding anaerobic coverage if you strongly suspect anaerobic bacteria as the source. However, this is often not needed in most neutropenic fever sepsis patients. And then think about when you want to add on, when you need to add on antifungal coverage. Again, this is not needed up front in most cases, but should consider it if the patient's not getting better, the patient is still having fevers after 4 to 7 days without a clear source, or there's an invasive pulmonary infection which makes you think of aspergillosis. And then certainly we want to involve ID and HEMONC early in these cases. So thank you for listening. That's all I have for the lecture today, and these are some of the resources that I used in preparing it.
Hi, this is Talia Ben-Jacob, and today we're going to have a review of diabetic ketoacidosis, DKA. I have no disclosures. Basically, we're going to discuss the basic theory of DKA, approach to treating it, and then troubleshooting potential complications, and just a good set of reminders for the most important things that you need to know when managing DKA. So DKA is a major life-threatening complication of diabetes. It usually occurs in type 1 diabetics. A lot of times we see it in pediatric patients, and that's how they actually present in order to obtain their diagnosis of diabetes. But it can also occur in type 2, although less rare. It's related to an absolute or relative insulin deficiency that ends up being aggravated by hyperglycemia, dehydration, and acidosis. You end up developing severe metabolic derangements and electrolyte derangements as well. Presenting symptoms usually include polyuria, polydipsia, nausea, vomiting, malaise, weakness, and as the disease progresses, if it goes untreated, you can develop altered mental status and obtundation. Other diagnostic signs are ketone breathing or Kussmaul breathing, and dry mucous membranes and decreased skin turgor. The Kussmaul breathing is basically a deep and labored pattern of breathing that is associated with the severe metabolic acidosis seen in diabetes. Because the patients are so acidotic, they want to hyperventilate in order to try to reduce the carbon dioxide in their blood to decrease their acidosis. So when you have a patient who presents with those signs and symptoms, you want to make your diagnosis. And basically the diagnosis is clinched with the triad of hyperglycemia, ketonemia, and high anion gap metabolic acidosis. Patients usually present with a glucose greater than 250 bicarb greater than 18 or a pH less than 7. They'll have ketones on a urine dipstick. Their anion gap will be greater than 12, and the anion gap is measured by subtracting the sum of chloride and bicarb from the measured sodium concentration. In addition, a confirmatory test is now measuring serum beta hydroxybutyrate level greater than 3.8. Now we talked earlier about acetoacetate. The serum beta hydroxybutyrate level will actually increase faster than the acetoacetate. So when wanting to make a rapid diagnosis, it's much better to measure the beta hydroxybutyrate level versus the acetoacetate. So now we'll talk about the management of DKA. And everyone should know that as of March 30th, we're going to go live with the Cooper Policy Network on treatment of DKA protocol. In addition to the fact that even if you forget everything that we're about to discuss with regards to management, it will be available for you as an EPIC order set. You just have to search under the order sets for DKA or diabetic ketoacidosis. So there is a foolproof backup in case you forget everything that we're discussing here today. So, the main therapeutic goals of DKA management include optimization of volume status, management of the hyperglycemia, ketoacidosis, management of the electrolyte abnormalities, and management of the potential precipitating factors. Before you start any of the treatment, you need to make sure to collect blood for the metabolic profile, the chem basic that we discussed, as well as serial sugars. And it's important to know that you must send serial labs either every 1 to 2 hours and finger checks every hour while treating DKA because there's potential for complications. So, number one, because these patients are dehydrated, you have to correct the fluid loss. Usually we start with an infusion of 1 liter or 500 cc's of normal saline over 1 hour the truth is any crystalloid fluid that you like, you can actually use. You also have to ensure a potassium level of greater than 3.3 before you start insulin, as insulin can drive potassium into the cells, and we need to make sure we keep the patient's electrolytes safe. You can only start your insulin once your fluid balance has been replaced and the potassium has been corrected. Of note, patients in DKA can present with severe acidosis. There's no need to correct the acid base unless the pH is less than 7. And in that case, you would correct with bicarb. Usually the acid base disorder will correct on its own when you give fluids and start the insulin and correct the potassium. In addition, if the etiology of the DKA is related to infection or stroke and MI, treatment for those must begin concurrently. So here's a really good flowchart / cheat sheet for anybody who's interested with regards to manage DKA. And once again, I just want to emphasize that successful treatment requires frequent monitoring of clinical and metabolic parameters. So meaning you're going to do finger sticks, you're going to do chem basics frequently every 1 to 2 hours, or just follow the protocol on the Cooper Policy Network. So of note, fluid loss averages 6 to 9 liters in DKA. The goal is to replace the total volume loss within 24 to 36 hours, with a 50% of resuscitation fluid being administered during the first 8 to 12 hours. Crystalloid fluid is the initial fluid of choice. However, especially when using normal saline, you need to watch for hyperchloremic metabolic acidosis with the chloride-containing solutions because you could end up inadvertently worsening your acidemia while trying to replace your fluid. Most protocols for initial boluses of isotonic crystalloid call for starting about 15 to 20 cc's per kilo per hour for the first hour, and then following that you can decrease the rate to 4 to 14 cc's per kilo per hour. In addition, if using normal saline, you need to monitor the serum because serum osmolality can change with the hypotonic fluids, and that can lead to an increased risk of cerebral edema, especially in patients with elevated glucose levels. Once your glucose levels fall below 200 to 250 of your blood sugar, you have to switch the intravenous fluids to dextrose-containing solutions because at that point you want to prevent hypoglycemia. Or if you so choose, you can actually decrease your insulin rate. All right, which will then lead us into the discussion of how to monitor your insulin and start insulin therapy in order to lower these blood sugars while avoiding hypoglycemia. So traditionally, an insulin bolus of regular insulin, about 0.1 units per kilo, is followed by a continuous insulin infusion. Usually, if the plasma glucose does not fall by at least 10% in the first hour of the insulin infusion rate, You can then bolus again and continue the insulin infusion. However, there is clinical significance as the phenomenon of hyperglycemia-induced insulin resistance. With reduction of the sugar, there may be a nonlinear decrease in insulin requirements. Of note, when the plasma glucose reaches 200 to 250, which you will know because you're going to be taking your Q1 hour sugars, the insulin rate can be decreased by 50% or to the rate of 0.02 to 0.05 units per kilo per hour. Also, during this time, when you're sending your chem basics, you're measuring your anion gaps as well as your serum potassiums. When the serum potassiums become less than 3.3, potassium needs to be administered because insulin administration and correction of the acidosis can drive potassium intracellularly. And this can actually lead to cardiac arrest. Like we said earlier, bicarb therapy is not indicated in mild and moderate forms of DKA because the metabolic acidosis will correct with the insulin therapy on its own. It is thought that the administration of bicarb can actually worsen the peripheral hypoxemia, worsen of hypokalemia, paradoxical central nervous system acidosis, can cause cerebral edema in children and young adults, and is an increased intracellular acidosis. Because acidosis is associated with worse clinical outcomes, if the pH is less than 6.9, you should go ahead and start bicarb therapy. So once again, the targets, serial measurements of every 2 to 4 hours of metabolic parameters should be done during DKA therapy and also to confirm the resolution of DKA. DKA is resolved when your plasma glucose is less than 200, your serum bicarb concentration is greater than 15 or 18, your venous blood pH is greater than 7.3, and the anion gap is less than 12. So, once insulin therapy post-resolution. So now that the DKA is gone, you're on this insulin infusion, how do you transition off? So basically, once the sugars are less than 200, the anion gap has been closed on 2 different chem basics that are 4 hours apart. You can start oral intake for the patient. In addition, you can start intermediate or long-acting insulin before termination of the drip. So basically what will happen is you will give the subcutaneous insulin, wait 1 to 2 hours before shutting off the drip, send a repeat chem basic an hour later in order to ensure that the gap remains closed. The dosing is calculated as follows. If the patient was on insulin prior to admission, you restart them at their same dose. If this is an insulin naive patient, you calculate their total dose at 0.5 to 0.8 units per kilo per day, and then you divide 50% as basal and 50% as prandial insulin before each meal. You also have to ensure that cereal finger sticks are done before each meal and at night before bed. So finally, in summary, the key points that we need to remind ourselves of with regards to DKA management are frequent labs, make sure you start fluids before insulin therapy, monitor for the hyperchloremic acidosis, make sure your potassium level is greater than 3.3 before the initiation of insulin therapy. You can give a priming bolus at 0.1 units per kilo and then initiate a continuous insulin infusion at 0.1 units per kilo. You can measure bedside glucose every 1 hour to adjust the insulin infusion rate. You avoid hypoglycemia during the insulin infusion by either letting the patient eat or starting dextrose-containing fluids, and then transition to subcutaneous insulin only when DKA is resolved. And for further information, once again, there's an order set in Epic as well as the protocol on the Cooper Policy Network. Thank you.
This presentation is intended as a quick introduction to the identification and management of sepsis and septic shock. We'll start with basic theory, then move on to general approach, and then finish with a few troubleshooting points. Sepsis is the dysregulated and maladaptive host response to an infection, resulting in life-threatening end organ dysfunction. It has characteristics of both hyperinflammation and immunosuppression, which paradoxically occur at the same time and are responsible in part for the sepsis. The consensus statement Sepsis 2 was an attempt to standardize our definition of sepsis. The Sepsis 2 definition used 2 out of 4 systemic inflammatory response syndrome, or SIRS criteria, plus an identified or suspected source of infection. SIRS criteria include fever or hypothermia, tachycardia, tachypnea, and leukocytosis or leukopenia. Under Sepsis 2, severe sepsis included 2 out of 4 SIRS criteria, plus evidence of end organ dysfunction. Similarly, septic shock included 2 out of 4 SIRS, with the inability to maintain a mean arterial blood pressure greater than 65 without vasopressor support. Published in 2016, Sepsis 3 focused on the use of Q-SOFA instead of SIRS as a way to identify which patients were most at risk of clinical decompensation and death. The Q-SOFA criteria include tachypnea, hypotension, and altered mental status. Sepsis 3 eliminated severe sepsis entirely and defined septic shock as 2 of 3 Q-SOFA with a lactate of at least 2 and vasopressor support needed to maintain a mean arterial blood pressure greater than 65 despite adequate IV fluid resuscitation. The transition away from SIRS criteria to Q-SOFA was in part to emphasize end organ dysfunction in the definition of sepsis. While typically manifesting as hypotension, lactic acidosis, and altered mental status, the multi-organ dysfunction seen in sepsis can include any of the above examples. With regards to the approach to sepsis, hypoxia is often one of the first identifiable signs of end organ dysfunction. Hypoxia is common in sepsis, and there are many potential causes. These include a primary insult affecting gas exchange, such as pneumonia or aspiration, pulmonary capillary leak with endothelial dysfunction, as seen in acute respiratory distress syndrome, and systemic mitochondrial dysfunction. Patients with primarily hypoxic respiratory failure may require supplemental oxygen through nasal cannula, non-rebreather, or high-flow nasal cannula. Patients exhibiting increased work of breathing or hypercarbia may benefit from non-invasive ventilation. This is also true of some specific patient populations, such as those with immunosuppression. However, for patients with any signs of impending respiratory failure, there should be a low threshold for endotracheal intubation and invasive mechanical ventilation. The 2016 Surviving Sepsis Guidelines recommend an initial crystalloid bolus of 30 milliliters per kilogram in septic patients. Lactated ringers is generally preferred over normal saline, given the later's risks of hyperchloremic metabolic acidosis and acute kidney injury. It is important to monitor volume status and respiratory status during fluid resuscitation in patients at risk of volume overload, such as end-stage renal disease and heart failure. The patient's response to the initial fluid bolus should be assessed and additional fluid challenges be given as needed. This assessment can include hemodynamics, lactate clearance, capillary refill, and evidence of end organ perfusion, such as urine output. It is important to determine which patients continue to be fluid responsive. Listed here are a few dynamic measures of fluid responsiveness. These include pulse pressure variation, passive leg raise, and bedside ultrasound. If available, invasive measures such as central venous pressure and SCVO2 can also be used, although these are thought to be generally less useful. While none of these parameters are meant to be used in isolation, a combination can give a sense of which patient will have an improvement in stroke volume and cardiac output with further fluid challenges. Excessive fluid administration has been shown to be harmful and should be avoided in patients where there is no benefit. One possible consequence is intra-abdominal hypertension and abdominal compartment syndrome. For this reason, bladder pressure should be monitored in patients receiving large volume fluid resuscitation. Antimicrobials should be administered as soon as possible after identification of sepsis, preferably within 1 hour. Some studies have demonstrated increased mortality with each hour antibiotics are delayed, as can be seen on the right. Culture data should be drawn first, but should not delay initiation of antimicrobials. When known, the antimicrobial regimen should be directed towards the source of infection. If the source is unknown, it is best to start with broad coverage and narrow enable. This includes coverage for both gram-positive and gram-negative organisms. Anaerobic coverage may also be needed, especially if abdominal source is suspected. The decision as to what antibiotics to start empirically should be based on risk factors, especially for pseudomonal infection and prior culture data if available. Certain patient populations may benefit from initial double gram-negative or antifungal coverage. These should be taken on a case-by-case basis, and infectious disease consultation should be strongly considered. The laboratory workup should be performed with strong consideration as to the suspected source. This includes MRSA nasal swab, urine Legionella antigen, and urine pneumococcal antigen for possible pneumonia. Clostridium stool toxin should be checked if C. diff colitis is suspected. While generally not useful during the initial resuscitation, procalcitonin can play an important role in de-escalation of antimicrobials later. Lactate is often used as a surrogate for end organ perfusion, and resuscitation guided by lactate levels has demonstrated benefit. Persistent lactic acidosis may indicate lack of source control or potentially a mixed shock clinical picture. Identification of the source and subsequently source control is vitally important. This often begins with bedside x-rays and ultrasound, but often will require more advanced imaging. In septic shock, Levophed is the initial pressor of choice. It has both alpha-1 and alpha-2 activity causing peripheral vasoconstriction, as well as beta-1 activity increasing cardiac output. For patients with unstable tachyarrhythmia, of which atrial fibrillation with RVR is most common, phenylephrine can be used. Sepsis causes a depletion of endogenous ADH, and vasopressin has demonstrated a mortality benefit when added to moderate doses of norepinephrine. While its effects on mortality are controversial, hydrocortisone has shown a decreased time to resolution of end organ dysfunction in septic shock and can be added to moderate doses of norepinephrine. The addition of fludrocortisone to hydrocortisone can also be considered. Now we're going to cover a few areas of troubleshooting in sepsis. Access is always a concern in a sick patient. While necessary in the initial early goal-directed therapy protocol, central venous catheters are not always necessary in sepsis or even septic shock. Vasopressor requirements of 10 micrograms or less of norepinephrine can be safely administered with an ultrasound-guided peripheral IV that is at least 18 gauge in diameter and has blood return. Pulmonary artery catheters are rarely used in 2020. For most patients, bedside ultrasound is adequate cardiac assessment, and there are many less invasive assessment tools such as NICOM. Colloids have no specific role in the resuscitation of sepsis and septic shock. Albumin has not demonstrated an improvement in mortality compared to crystalloids. However, albumin should be considered in patients with an underlying indication such as spontaneous bacterial peritonitis. Albumin can also be considered in patients requiring significant boluses of crystalloid. There are no specific blood product transfusion thresholds for sepsis. Generally, transfusion of packed red blood cells to improve SCVO2 is no longer indicated. Septic patients, however, do have high rates of disseminated intravascular coagulation and may require cryorepletion. Finally, with regards to de-escalation in septic shock, it is generally recommended to discontinue vasopressin last, as this reduces the rates of hypotension. Systemic steroids should be weaned after the patient has demonstrated stability off of vasopressors. A steroid wean is favored over a hard stop. Given our concern for excessive fluid, diuresis should also be considered for patients demonstrating hemodynamic stability.
This is a topic of healthcare-associated infections. We will cover central line-associated bloodstream infections, catheter-associated urinary tract infections, and ventilator-associated pneumonia. We will start with central line-associated bloodstream infections. Following proper insertion practices is the key to preventing infections. Performing hand hygiene before insertion, adhere to aseptic technique, use maximal sterile barrier precautions. So wear your mask, your cap, gown, sterile gloves, eye protection, and sterile full body drapes. Choose the best insertion site to minimize infections. Avoid sites such as femoral site for obese adult patients. Prepare the insertion site with chlorhexidine and alcohol, and place a sterile gauze dressing on or a sterile transparent semi-permeable dressing over the insertion site. So once the central line is in place, make sure you review if the patient still needs the central line and remove any unnecessary central lines. You can do audits such as checklists. Here we have an acronym that reviews several patient data on a daily basis that includes central lines, extubation, and Foley catheters. That's FASTER flag is the acronym, FASTER. FLAG stands for feeding, analgesia, sedation, thromboprophylaxis, extubation, restraints, Foley, lines, activity, and glucose control. We will then move on to catheter-associated urinary tract infections. In this, I have on the left side a Foley catheter with a drainage tube and a collection bag. On the right is a catheter that is not indwelling, which is a condom catheter for males and a periwick catheter for female. So what are the risk factors? As we move on to the next slide, the priority recommendations for appropriate urinary catheter use. Insert catheters only for appropriate indications and leave in place only as needed. So what are the appropriate indications? I'm going to go through some examples. So patient who has acute urinary retention or bladder outlet obstruction need for accurate measurements of urinary output in critically ill patients. Patients who've undergone certain surgical procedures, so urologic surgery or the surgery on contiguous structures of the genitourinary tract, or anticipate prolonged duration of surgery. In this case, the catheters that were inserted should be removed in the PACU. Patients anticipated to receive large volume infusions or diuretics during surgery need for intraoperative monitoring of urinary output to assist in healing of open sacral or perineal wounds in incontinent patients. Patients who require prolonged immobilization, potentially unstable thoracic or lumbar spine, multiple traumatic injuries such as pelvic fractures, to improve comfort level for end-of-life care if needed. Then let's review some of the examples of inappropriate uses of indwelling catheters as a substitute for nursing care in the patient with incontinence, as a means of obtaining urine for culture or other diagnostic tests when the patient cannot voluntarily void, for prolonged postoperative duration without appropriate indication. So for operative patients who have an indication for an indwelling catheter, make sure you remove the catheter as soon as possible postoperatively, preferably within 24 hours. So consider alternatives to indwelling urinary catheters. As I had shown in the previous slide, the condom catheters for the male and the periwick condom catheter for females. Consider intermittent catheterization for patients with spinal cord injury, bladder emptying dysfunctions, or neurogenic bladder. And perform daily audits again to assess whether each indwelling catheter is still needed. Next, we move on to ventilator-associated pneumonia, which is a pneumonia that develops more than 48 hours after endotracheal intubation. Now I'm going to review some nomenclature, VAC or ventilator-associated conditions. These patients are patients who've had a stable or decreasing minimum daily PEEP or FiO2 followed by a rise of PEEP of 3 centimeters or a rise in FiO2 of 20% sustained for 48 hours. IVAC is an infection related to ventilator-associated complications where the patient has VAC plus temperature or leukocytosis or leukopenia, and one or more new antibiotics continued over the next 96 hours within 48 hours before or after VAC onset, excluding the first 48 hours of mechanical ventilation. Then there's possible pneumonia, which is IVAC plus sputum or BAL with 25 neutrophils per field, or positive culture for pathogenic organisms. And there's probable pneumonia or IVAC plus sputum or BAL with 25 neutrophil per field and positive quantitative, semi-quantitative culture for pathogenic organisms. In this slide, we're going to review what steps we can take to reduce ventilator-associated pneumonias. This is an acronym VAP, stands for ventilation, accompanying measures, and preventative measures. The main ventilation reducing risks are by avoiding intubation when possible, so using non-invasive positive pressure ventilation when possible. For our COVID-19 patients, we would avoid using non-invasive ventilation. Minimize sedation, manage ventilated patients without sedation when possible, interrupt sedation once daily, and pair spontaneous awakening trials with spontaneous breathing trials. Minimize and improve physical conditioning, provide early exercise and early mobilization. The preventative measures, changing the ventilator circuit only when visibly soiled or malfunctioning. Endotracheal tubes with subglottic drainage of secretions, regular oral care with chlorhexidine, and elevate the head of bed 30 to 45 degrees. These are things we can do to keep our patients safe, and thank you.
Well, that does it for Critical Care in 10 minutes or less. If anyone has a specific topic that they'd like us to explore in 10 minutes or less, please feel free to send me an email, and we'll do our best to get that education out in real time. I really appreciate everyone's time and attention. From all of us here at Cooper Critical Care, we thank you.